Public Health will come to order. The clerk will call the roll.
Click.
Present.
Campos.
Present.
Jaton.
Here.
Johnson.
Here.
Jones of Harris. Jones of Harris.
Oh, present.
Jones of Dallas. Oliverson.
Here.
Price.
Here.
Smith. Tenderholt.
Here.
A quorum is present. Good morning, everyone. We've got a pretty lengthy agenda today, and I'm hopeful that we can move through in an efficient manner. As a reminder, if there's anyone who wishes to testify on any of the bills we'll be hearing today, you must register on the electronic witness affirmation kiosks located outside the hearing room before you testify and indicate each bill that you'd like to testify on. As per the committee posting, I will limit testimony time and number of witnesses to ensure consideration of posted and pending business, especially if testimony would cause the hearing to extend into the next calendar day. I'd like to inform everyone that the public comment portal opened when the hearing was posted on Wednesday afternoon. Any Texas resident is welcome to offer their comments on the portal. Each member of the committee is able to view the comments as they are posted. The comments will be posted and available on each bill's webpage after the portal is closed. The chair lays out House Bill 4343 and recognizes Representative Bonin to explain the bill.
Good morning, and thank you, Chairman Click and members. Last session, the legislature passed House Bill 3459, which assisted physicians through the burdensome prior authorization process. This legislation required an HMO to provide an exemption from prior authorization requirements, or what is known as a gold carding status, for commonly approved procedures on a physician-by-physician basis, and this would be contingent upon the physician receiving a 90% approval rate for that requested procedure or service. A TDI implementation study of this legislation found that only 4% of providers met the threshold for evaluation for one or more services, and only about 3.3% of providers actually received an exemption. The exemptions were approved for about 3/4 of providers who met the evaluation threshold. Prior authorizations can or are actually a very substantial cost to a medical practice. Some data from the Texas Orthopedic Association indicates an additional cost of over $500,000 in capital and employees. Now, that would probably be better put into context on a per physician basis. Anecdotally, from personal experience, I'd say it's about a half an FTE just to do prior authorizations in a doctor's office. So if you had a 2-physician practice, that would be one full-time person simply handling prior authorizations that are almost always approved in the end. So House Bill 4343 builds upon last session's efforts in attempt to streamline this process and address the practice of medicine that often occurs through the prior authorization system. So the legislation that was passed last session really created a national conversation about this topic, but in practice, it's still been relatively inefficient, and that's what the data has shown. So in this case, practicing doctors should be able to review prior authorization requests, and as such, physicians with an administrative license should not review these. We allowed that, but an administrative license obviously does not mean that you have sufficient background in neurosurgery or gastroenterology or whatever it may be. Physicians reviewing prior authorizations are in a position to either approve or deny patient treatments, and that could include medications or surgical procedures. This legislation adds the direction of a utilization review conducted by a utilization review agent to define the practice of medicine. The bill allows the medical board to initiate proceedings against a physician after they receive an allegation that the physician has directed a utilization review in an arbitrary manner or without a medical basis. Under this legislation, the medical board may penalize a doctor if the utilization review results in a serious injury or the death of an individual. And I have a committee sub. I don't know if that's going to You do not have that? Okay. So there are some contemplated changes that we will come back to you that would do a number of things that have been discussed, and I'm happy to visit with you at a later
You
time.
can explain what you're planning to do with this,
Yeah, so some things that will likely happen is we'll extend the time a physician has to accumulate an approved number of procedures or services. Right now, it's 6 months, and you have to have 90% approval rate with a minimum of 5. So by extending the period of time, you can accumulate the requisite number. So it will extend it to a year. It will ensure that TDI confirms that the service was covered by insurance before the medical board initiates a proceeding against a physician if there's a complaint with respect to a physician who's doing prior authorization reviews. We'll likely clarify that the medical board can review medical procedures and medications, and add language to require insurers to use data from other plans to combine analysis across affiliated insurers. So right now, it's specific to a given product. So that is, as you can imagine, a real problem because there are multiple carriers and they each have multiple products. And then if you have to meet the requirement for each specific product to get to the requisite number and approval percentage is very challenging.
questions, members?
Madam Chair.
Dr. Alverson?
Thank you, Madam Chair. Appreciate it. Dr. Bonin, I appreciate you bringing this bill. As I think some folks know, that this bill came through my committee last session, and we spent a fair amount of time talking about it. So to be clear, this bill sort of addresses some of the issues that were raised during implementation and such, and you're repealing the administrative medical license piece. My position, and I think you and I might share this, is that if you're denying somebody access to healthcare or refusing to pay for it, saying it's not medically necessary, that is practicing medicine, clearly. Is that your contention as well?
So that's a fundamental position of the legislation that I carried last session and that we passed into law, is that if you're deciding whether somebody may or may not receive a medication, if you're deciding whether or not somebody will or will not have a surgical procedure, that is by definition medical decision making, that is practicing medicine. And so the safety net for patients was to say those physicians should be licensed in Texas and accountable for that medical decision making to the medical board. The statute did not specify precisely, other than an effort to say it should be in a relevant specialty. And so administrative licenses were adopted in the rulemaking process. And an administrative license, as you know, is non-specific to any...
Not actively practicing medicine, right?
It is precisely what it sounds like.
So you end up with a situation where somebody may not even be board certified, but certainly not up to speed on the current best medical practices within a particular area. I mean, the whole point of your bill last time, as I recall, one of the points of it was to enforce the idea that if somebody was doing a utilization review on, say, neurosurgery, the person should have the same level of knowledge as the neurosurgeon making the request for treatment to be covered, right? And so you don't have a pediatrician making a decision about whether brain surgery is indicated or not, because they have no background and training in that.
So that's literally happened where pediatricians were on the phone with surgeons discussing whether or not a procedure was appropriate. That is precisely what we're trying to address, but now you have somebody who works full-time administratively and doesn't even practice and has no clinical background that under current law would be considered acceptable to review these.
And the other piece that I remember we talked about, I'm curious, does this bill resolve the issue of, there was a question that was brought forth about what happens if a doctor doesn't perform a certain number of tasks that lead to utilization review, so that there's no sort of, quote, minimum number or threshold that needs to be achieved in order to qualify for a gold card. So, you know, like 90% of a sample size of 2.
So we're trying to address that. It was in the rule, it was left to rulemaking, and this would actually attempt
cleans
to
that
clarify
up.
that.
Okay. All right, well, I appreciate you bringing the bill. Thank you very much.
Thank you.
Other questions, members? The question I have on this, will this just be for those where there's been a medical review? I mean, because there are a lot of circumstances in which claims can be denied.
Yeah, so this is on the front end. This is before anything has been denied. And the issue is that in a typical practice, you have to get approval for any number of activities, whether it's diagnostic, whether it's a medication, whether it's a procedure. And what will happen is they're approved almost every single time. But yet it causes delays and it causes expense. And then in the most frustrating scenario, you'll have a situation, and it's happening right now today across the state in different doctors' offices, where a patient's upset that they're supposed to have something done. It's not been authorized by their insurer. They call the insurer says, well, we haven't gotten the information from the doctor's office. The doctor's office has sent it in 5 times. And then the patient calls the doctor's office and is angry that they're not providing for their needs. And so now you've poisoned the relationship between the patient and the physician's office, because the insurer has put this arbitrary process in place where inevitably it will be approved. It hasn't been denied, and it's not going to be denied. It's just a process that's been put in place between the recommendation of the treating physician and the patient.
Okay, but it seems that some of these issues, are they not under the purview of the insurance board currently or not? I mean, if a patient wanted to file a complaint, who would they file that complaint with?
If it's about the insurer, they could file it with TDI.
Okay. But under this, your bill on...
So under current law, what we did is we said, okay, look, when the insurance company hires a doctor to review these requests, that doctor is making medical decisions. And so that is practicing medicine. So the physician should be accountable for those decisions to the medical board. And that's already in statute. This adds the tools that the medical board needs to have clarity as to how would they handle a complaint about a physician that was reviewing these requests and making poor choices. This seeks to respond to feedback that was received in the interim from the medical board about that process and how it should work. The second piece, which Dr. Oliverson was referencing, is, so who's qualified to review these things? Can it just be anybody? And if someone with an administrative license who has an MD after their name is allowed to do that, that doesn't mean they actually have any relevant expertise to what is being requested. And so those are the cleanups that we're trying to do with respect to that review.
So this would not be a situation where if you had a fee dispute that you would go to the medical board?
Correct.
Okay.
Yeah, this is strictly the medical decision-making, whether or not that medication or whether or not that procedure or whether or not that test should be approved. And as a practical matter, harm would have to have been brought about to the patient because of the denial for the medical board to have any cause to want to review that. And then it would be handled as if it had happened with the treating physician, essentially.
Okay, thank you. Any other questions, members?
Thank you.
Okay, we'll reserve your right to close and begin hearing public testimony. Chair calls Christine Keene. Up next will be Jennifer Kinman.
Hello. Thank you, Madam Chair and Vice Chair Campos from San Antonio, and committee members for allowing me to testify today. My name is Christine Keene. I'm testifying on behalf of myself as Chief Operating Officer of TSAOG Orthopedics and Spine, as well as the Texas Medical Association and the Texas Orthopedic Association in support of House Bill 4343.
Please begin.
Thank you for allowing me the opportunity to provide boots-on-the-ground testimony regarding this bill. I've worked for TSAOG, a physician-owned group of 39 physicians in San Antonio, for 22 years, and I've witnessed the direct impact the increasingly demanding prior authorization process has made on physicians, staff, and most importantly, our patients. Many have pointed to House Bill 3459, the Gold Card Prior Auth Law, from 2021 legislature as one of the most important laws for surgeons, physicians, and their patients since the 2003 lawsuit tort reform and surprise billing, and I could not agree more. The gold card law literally spurred the conversation in both Washington and other states to create their own gold card bills. In December, the Biden administration asked for stakeholder comments about creating a gold card at the national level. This spotlight on gold card concept is thanks to this Texas legislature. The law has even pushed insurance carriers to critically review and proactively remove some of these hurdles in accessing care. Intuitively, I knew that the overwhelming majority of our requests for pre-authorizations are improved, but in 2021, I asked our data scientist, Dr. Mike Profit, to run our data and give me the actual percentage of approvals. So we ran our 2020 data on over 30,000 authorization requests, and he found that over 99% of the time, our requests were approved, but not without countless hours of effort, administrative cost, and patient safety concerns when it comes to delaying care. It made no sense to me why we were all participating in this elaborate administrative process to request permission if almost 100% of the time we were approved to proceed. The Gold Card law attempted to address this burdensome process and remove barriers for patients by reviewing the results of physician requests and gold carding physicians who were approved 90% of the time for a particular healthcare service. If the physician met this standard, then they could bypass the process and simply proceed with scheduling the patient for the ordered service. I'll never forget how elated I was when I heard that this became law nearly 2 years ago. It's also a pro-patient bill, and you should understand that, as unnecessary delays in care pose a threat to patient safety and are costly when patients forego treatment or end up in the emergency room due to the delay in care. While we should be very proud of what we've accomplished to date, we're not done. The implementation of House Bill 3459, which was the first of its kind, was complicated, and the rulemaking process to implement the intent of this bill has not produced the results expected. The Texas Department of Insurance reports that only 3% of providers were positively impacted by the bill, and the primary reason for this is due to providers not meeting the threshold for services. House Bill 4343 addresses this and others.
Thank you. The chair recognizes Representative Smith and Collier are now present. Members, any questions for the witness? Representative Alverson.
Thank you, Madam Chair. Christine, I appreciate you being here today, and I appreciate you bringing your expertise. So I know your testimony was limited, but I wanted to really kind of, because I understand you're sort of the end user of this,
That's right.
managing, a practice for multiple orthopedic surgeons. And I know when I went back to the operating room in my day job, this was a law that many of my orthopedic surgeons were really hopeful was going to streamline access to care for their patients that were being, basically just as you said, denied. So I'm curious, your perspective, how has the implementation gone? And are there things that we are fixing here with this legislation that you're like, yay, because that was one of my concerns kind of thing. Can you tell us about your experience?
Yes, I can tell you that the TDI's survey of the insurance carriers of finding that only 3% of doctors were gold carded is the same as ours. It's been a very difficult process, but expected. Here's what I'll say. I'm very positive about what we've accomplished, but we have to go further. 4343 has to get through in order to make this be something that we are proud of as Texans.
How many of your doctors received their gold card in your practice in San Antonio?
I had about 13 that were for individual different services. I really believe that what we missed here is on the particular healthcare service and the number of services that you're allowed to review. That 6-month window is too small of a period of time per insurance carrier because each insurance carrier is issuing a gold card. I believe that it needs to be on all services that physician has requested from that insurance carrier. If you're 90%, you're going to be more than that. You're making good medical decisions. That's what we're trying to figure out here, is the doctor making good medical decisions. And I believe that that's what this bill will address for us.
In what kinds of services were your doctors having difficulty getting approved through utilization review that this is kind of resolved?
Every single one of them.
I mean, are we talking medical
MR
treatments,
oh,
surgeries?
yeah,
Can you
yeah.
give us a couple of examples,
Yes,
maybe?
all medical services, so MRI approvals, surgery approvals, medication approvals. It's pretty much anything we order, and insurance carrier has rules and regulations on what needs to get pre-authorized. And those rules are constantly changing and are being enhanced. I've even seen one insurance carrier that requested that the actual MRI films, the actual films that were taken, be sent to the insurance carrier so that they can review them.
And what's the average length of time that one of these processes takes before a patient gets approval, say for an MRI?
It's a minimum of 3 days, but we've seen it's up to 5 days. And if it is something that is needing to be reviewed by somebody else, it can take up to 7 days.
And do these things stack? So in other words, let's say you have a patient that comes in that tore up their knee really bad. They went skiing, they tore up their knee. So you're going to send them for an MRI.
Right?
So that's going to be delayed 5 days.
Yep,
So then the MRI is going to say that they need surgery.
right.
So that's going to be delayed another 5 days? Do
That's
they
right.
stack like that?
They
And
absolutely
physical
do.
therapy then gets denied?
Same thing, same process.
So
It is-
you could, over time, in the care of one patient for one medical issue, rack up several weeks' worth of delays in care.
Yes, absolutely. We have patients right now that ask, can I just pay cash for this instead of going through my insurance carrier so I don't have to wait for it to be done?
And when a patient's having surgery, it's not just the approval to do the operation, is it also the approval of doing it? I mean, so you've got the doctor, the facility. Are there multiple issues? I've heard situations where patients are literally sitting there in the waiting, in the pre-op area with their IV in, and we still don't have the the prior authorization completed.
We've had that happen. We try to avoid that as much as possible, but it has happened.
Okay. All right. Well, I appreciate you being here. I appreciate your experience. Hopefully this will sort of reduce the red tape and get people the care that they need, and that might actually do something to bring the cost of healthcare down for a change.
I'd appreciate it.
Other questions, members? Thank you.
Thank you.
Chair calls Jennifer Kinman. Next on deck will be Jamie Dudesening. I show you're Jennifer Kinman, and you're representing the Texas Orthopedic Association, is that correct?
Yes.
And you were for the bill?
I'm sorry?
And you're for the bill
Yes.
already?
Yes. Thank you, Madam Chair, Vice Chair, and committee members. My name is Jennifer Kinman. I am with Ortho Lone Star. We are a 150 physician practice of orthopedic surgeons and musculoskeletal medicine physicians across the state of Texas. We have offices Dallas, Houston, Austin, and in East Texas and beyond. We are in support of House Bill 4343. We appreciate the progress on this very burdensome issue for our providers. In addition to the comments made by my colleague, I would like to comment on the difficulty we as providers have found in just learning whether we have exemptions granted to us or not. And unfortunately, it requires us to therefore check on every surgery, MRI, physical therapy that we order anyway. And it kind of, unfortunately undermines the intent of the bill. The number of physical therapists we have on staff is as well as 73 across 40 different offices. We have one payer in particular who's done a remarkable job with an online source that we can find information. And in that source, 85% of our providers received one or more exemptions. So very strong showing, and we can actually use that information. We've received other letters from payers that will say you are not supposed to be seeking authorization because you're exempt, yet we never received the exemption. Multiple requests to payers have gone unanswered for our actual exemptions that we have. So it's been a challenge, and I think that it's going to be a continuous work in progress on this very important topic. But as for this House bill, I think it's helping in a number of ways, and we are in support of it.
Questions, members? Dr.
Sorry, I
Alverson.
feel like I'm the only one asking questions here, but I appreciate it. Thank you, Madam Chair. Can you talk a little bit about, Jennifer, as you're interacting with insurance companies, obviously this is a relatively young law, so to speak, and it's kind of the first of its kind. Are most of the folks that you're dealing with on the insurance end, are they located here in Texas or are they out of state? And do they know about this law or do they not? Because I've heard stories of people like, had to be transferred to the third person before suddenly somebody said, oh yeah, I know about that law that was passed in Texas.
So most of the larger payers do have provider relations representatives in the state. And if we can get to them and get an answer from them, they generally will know what it is. Whether they know the answers that we seek, we may be referred to another party. It's really been a challenge. We need to have it online, available for us to search, when we're needing to authorize an encounter or surgery or, what we're trying to do.
Yeah, one would think it might be helpful since we have directories and things like that that are
Absolutely.
online by carrier to be able to know. Obviously there are contracts and networks, and so this is just one other little piece of information.
It is.
Your experience is also, as I've heard others share, is it similar that, with respect to prior authorizations generally, that greater than 95, 97% of them are granted? It's just sort of a delay tactic?
Absolutely. And we're even seeing the payers requiring us to submit the authorizations further and further in advance.
Yeah.
So, I've heard of 15 days in advance we have to submit in order to get our procedure authorized, timely. So that further delays the care, right? Because we have to schedule it that far out to give us enough to submit it in time.
I think, we talked about this last session, but I think, prior authorizations when they were created had a very useful purpose, which was to prevent unnecessary care from being provided. But the reality is that if greater than 95% of them are granted anyway, then you're not using them appropriately. And so I would say that my feeling is that this law wouldn't have been necessary had prior authorizations been used appropriately. But obviously that, delaying is still not paying claims, and not paying claims is still money in the bank. And so, it's just sort of one of these things. We do know that there are studies out there that show that if you put a prior authorization on any medication, it reduces the number of prescriptions for that medication by about a third. So it's a strong influencer of behavior, and the question is, how do we get back to a place to where it's being used appropriately? And I hope you feel like this law does that.
It does, and it definitely sets a standard for the nation. This is not just a problem in Texas, and actually for the number of self-insureds and ERISA plans that are out there, we look forward to this having some traction nationally as well.
Hope so. Thanks for being here today.
Other questions, members? Thank you. Chair calls Jamie Dudensing. Jamie, I show you are representing the Texas Association of Health Plans, and you're neutral on the bill. Is that correct?
That's correct. My name is Jamie Dudensing. I'm the CEO of the Texas Association of Health Plans, and I'm speaking on the bill today. Just really quick on prior authorizations. I do think it's helpful to know that in Texas, we're required to only have a prior authorization when it's based on medical evidence or what is backed by the medical community. A very good, we've heard quite a bit on the administrative complexity of them, and the goal to try to reduce those administrative pieces. At the same time, I think it's important to know that there are things that they do prevent. I can give you two anecdotal examples. When kids in foster care, the comptroller had the big finding that they were being prescribed too many psychotropic drugs and the wrong psychotropic drugs under a certain age. They were being over-medicated. Prior authorizations were put in place to help protect those children. Another very good example were braces on baby teeth that happened where the prior authorization was working. It was being approved 90, 95%, 99% of the time, but then the state stopped processing it. And then we had a huge amount of fraud that ended up with the state going after $250 million of fraud, waste, and abuse. So there are important points to where prior authorizations are important. At the same time, the need to reduce that administrative process that physicians have to go through in their office to process them. So there are a few things I would like to speak on the bill that we would like to see some improvements on, and I haven't had the time to read the sub yet, some of which could be in there on this. And one on the license piece with the medical board. In Texas, health plans are not allowed to hire a full licensed physician. The medical board created a separate license, an administrative license, that has the exact same requirements as a full license does, but that you're not allowed, if you work for an insurance company, to have that full medical license. So it really puts us in a catch-22. If you're not allowed to have an administrative license, but you're also not allowed to hire someone with a full license. So we really feel it's important to have the clarification that we will still be allowed to hire doctors. Otherwise, we wouldn't be able to have a license in the state of Texas anymore on that part. So while we do understand the intent, we do think it's important that we still be able to live up to the law and hire a physician to process this information in Texas. The second piece on the introduced bill, we do think it's important that it was discussed last session that there is a history of appropriate and safe care, and that's more than 0 times or more than 1 time. As was discussed in the layout, it does sound like the sub's going to have it be the 5 over 12 months, which ensures that there is still some history happening. But we do think that that is an important part of this. The other part of this that we do think that there could be improvements to the bill last session. And that is that, as all that's been discussed is on this front end piece. And that is, we're going to trust doctors that have a history of safe and appropriate care to take away this administrative workload from them. But the question is then what happens on the back end after, care has been delivered, claims have been paid, and you start to see this pattern. The bill from last session also restricted us, even though I don't consider that the same administrative burden, restricted us from looking back at those claims. The only thing we were allowed to look at was just a partial definition of fraud. And we would like to see the full penal code definition of fraud be included of what we're allowed to look at. If it is considered a penal code offense, we feel like we should be able to go back and review that. And we don't believe it would increase administrative burden for a physician because it's us just looking at the own claims data that we have. And those are some of the big improvements that, we'd like to see overall in the bill just to make sure we can process it. And I'm happy to answer any questions.
Questions, members? Representative Collier?
Thank you. Oh, I'm in the wrong place. I just want to go back to the part where you said the physician doesn't have a full license. Mm-hmm. What type of license do they have?
So the medical board and I don't know that they were given legislative direction to do this, and I think it may have been like 50 or 20 years ago, decided that if you worked for an insurance company, that you couldn't hold a full medical license. So they created a brand new license called an administrative license that had, and I've listened to the medical board testify on this a few times. They say it's the exact same requirements to achieve that license. It's just that you're working for an insurance company. You're not practicing. You're not in an office practicing anymore. At that insurance company, you're not suddenly practicing and writing scripts on that piece. And so our issue, we don't have a problem with the medical board having some oversight into a physician where you have these things. If something really bad happened, I think our issue is just making sure there's clarification.
Okay, all right, so back to my question. Mm-hmm. So I asked about the type of license, the administrative license. So this person that has an administrative license, they don't actually see patients on a daily basis. They're not involved in the process of filing, pre-authorization forms and trying to make sure that the forms are, all the I's are dotted and the T's are crossed. Now.
In Texas, it's been purposely set up that you are not allowed to, you're no longer allowed to practice medicine when you're working for an insurance company because they're keeping this separate.
We can call up
Well, no, because she brought it up, so I want her to explain it.
Yeah.
And so in this bill, they remove that.
That's correct.
And so that's a better practice to do that because this person, now you wouldn't have to have just an administrative license.
What I
Under
would
this bill.
say is that you're required to have the exact same level of education, expertise to have.
But you're not on the ground. You don't have boots on the ground,
That's
basically.
correct. But we're also not allowed to hire someone that's doing that. And in Texas, to have a license for health insurance, you have to be able to hire a full-time medical physician.
Okay, so that's the problem.
It's just a clarification that needs to happen, that it still allows us to hire a doctor in the state of Texas so that we can still exist.
Okay, but then maybe you need to talk to the bill.
We have, yes.
Thanks.
Other questions? Representative Jones?
So you're with the insurance companies.
That's correct, yes, ma'am.
So you want for the insurance companies to be able to hire a physician that has like a full medical license? Because I'm just sort of confused, so I need you to help me out.
No, it's okay. We're required by state law to have a physician that runs our entire what's called utilization review program, which one component is prior authorizations. So you cannot have it has the entire plan, the entire function of it has to be run by a doctor, someone that, and as of last session, someone that is licensed in the state of Texas on that front. So we're required to do that.
But I guess my confusion is this: if you're not with boots on the ground and you're not seeing patients, then why do you want for that? Why is that a hindrance to you?
It's not that it's a hindrance, it's just a requirement in state law that we have to have a doctor run utilization review for an insurance company. It can't be run by anyone else.
No, I'm not, that's not, so maybe I'm being inarticulate. Why does the doctor, or I'm sorry, the physician that's over this program have to have a full medical license? What's stopping? Why are you saying that's not good?
Oh, I'm not saying that's not good. I guess what I'm saying is that's a new requirement in the bill, and coupled on top of older requirements and existing requirements, there just needs to be a clarification that we can still hire a physician while ensuring that that physician also has a full medical license.
Why does the physician have to have a full medical license?
The bill is the new bill in front of you is requiring them to have a full medical license so that there can be more accountability by the medical board over the action that physician takes when making decisions on prior authorizations.
Okay. So if the bill before us is now requiring physicians to have a full medical license, I think I heard you complain that you couldn't do that before. Doesn't that remedy the problem, or am I?
No, it's not really a complaint. It's just a clarification we've asked for to make sure we can still hire that person that now has a full medical license, that the medical board will not stop us from hiring them and them working full-time for a health insurance company.
I don't know that my question was answered, but how about this? We can talk later.
Okay.
Because I'm still
Sorry.
confused. All right, no worries.
Other questions, members? Representative Albertson?
Thank you, Madam Chair. I'm just curious, Jamie, does a doctor have to be employed by an insurance company to review
They're
prior
required.
authorizations? Do you ever work with a physician that's not a full-time employee?
We're required to have a full-time medical
But,
director that
but when you're seeking out expertise, which you have testified before, and I think we all agree, can sometimes be a little challenging depending on what the utilization review prior authorization is looking for. Is there ever a circumstance where a physician reviews a PA who is not a full-time employee of a health plan?
I believe there are, yes, because the requirement for it to be a same specialist is
Right.
impossible.
That's what I'm getting at. So when
So
you
it's-
say you have to hire them and they can't have this license or whatever, you don't have to hire them. If you had a gap in knowledge and you needed an expert, you could go out and contract with whatever licensed physician is a specialist in that area that you thought would be a a fair arbiter of the situation, right? You're free to contract with whoever you want.
That's absolutely correct. What I would say is the medical director is required.
The medical director, right, I get that, but how many prior authorizations does the medical director review themselves?
I don't know. I can find out.
Okay, and then the other thing I just wanted to clarify, you gave a couple of really good examples, but I think if I understood the circumstances correctly, those were both Medicaid examples.
That is
This bill
correct,
doesn't
but
deal with Medicaid.
We also see 30-day opioids prescribed
Okay.
for individuals that have dental procedures.
I mean, I'm not saying there's not a use for prior authorization. I think the contention that we're making here, that this bill, even when it passed last session, was making, is that if greater than 95% of prior authorizations are granted after 5 days, you're probably overutilizing the technique. Would you agree with that?
I would say that we are definitely in agreement on the need to reduce the administrative burden on PAs. I think where I was coming from more is that's fine, but, make sure there's still.
Yeah, I mean, I think it's a useful technique, it's a useful thing, and I think, again, ultimately, you do have responsibility as an insurer to make sure that the patient's getting medically appropriate care, and I don't think anybody wants to take that away. I think we found ourselves in a situation over the last decade where prior authorization essentially gets put on everything, and it becomes relatively, 9 times out of 10, it's just an administrative burden for care that's ultimately going to be approved. You know it, the doctor knows it, everybody knows it. It's just an extra 5 days of waiting and aggravation and delay of care for the patient, during which time their condition could worsen.
And which is why we've really had good conversations with stakeholders about just making, this 12 months with the 5 incidents, still ensure there's some history, increases the number of physicians that will be eligible for one. Like I say, I think more of my ask would really be that we would have a little bit more flexibility to look on the back end.
You have an industry trade group, obviously. Has there been any conversation? I understand the Biden administration is talking about this at the national level. Has there been any conversation with respect to some of the testimony that we've heard of, each individual carrier has their own gold carding process? Has there been any conversation about maybe collaborating together? I would assume that insurance companies typically use the similar or same procedures for determining if something's medically necessary or not. It may be that there's cost savings and just throughput savings by having a standard process for all carriers. Have you all talked about that at all?
I have not been given the impression that that would ease administrative burden on the insurance side. I do know that this was already pretty complicated, and as you can see, there's still
totally.
steps happening to implement, and I would probably say that moving to that would be an entirely other level of complexity on
But it
top
could-
of us just trying to.
It could result in massive simplification. I mean, if you think about it, you have national standards for a lot of things that you all do where essentially, you're using the same CPT codes and the same, a lot of times you're using the same billing software or same databases and stuff like that. We obviously use the same Medicare fee schedule. It just seems to me like that is something, if you wanted to, and you wanted to make it less expensive and easier and more consistent across the board and really sort of embrace the mission here, and preserve the right to do PAs, it seems to me like that's one thing y'all could explore as an industry, as a standardized gold carding process, so that doctors wouldn't have to, gold card with every single individual plan.
I think we would be interested in studying a number of ways that could reduce the burden of where we're, processing every 6 months, how that's working right now.
Right.
Are there easier ways to do this? I would say right now it's probably helpful just to get this, and these new things done right.
Sure.
And this working well, and then potentially look at studying what are the options to reduce sort of the administrative burden that's created from doing it also.
Okay, cool. All right, thank you so much.
Other questions, members?
Yes, thank you.
Representative Smith?
Good morning. Tell me again who you work for.
The Texas Association of Health Plans. So all of the industry association that represents all of the health insurers, the Medicare Advantage, and Medicaid managed care plans, the contract with the state of Texas.
Are there standards for the amount of time that should be required to process a utilization review?
Yes, in fact, in Texas, we have the shortest time frames in the country. It's required to be done in 3 days. The pre-review part of it has to be done within, before that 3 days, we have to make a decision on that third day. There's very specific provisions on the appeal process. Also, every decision can be appealed to an external, what's called an external review organization, or an IRO, and that is an independent physician, so that you have an independent physician making a decision on that appeal, not the physician in that office or not the physician working for that insurance company. And we have very tight timeframes on those that are faster in the country. I believe our PA process in the commercial market, which is 3 days, like for example, I think ERS is 14. Most of the rest of the country is 2 weeks. I think Medicaid's 2 weeks. So we have a very tight turnaround time for PAs in the commercial health insurance market.
Is that 3 days by statute?
That's correct, sir.
Okay. And that appeal, can it be taken advantage of by either side, by either the payee or the payor?
It would either be the physician on behalf of the patient, or the patient would appeal it.
That's kind of interesting to me, and there's something I'm not understanding here, because it sounds to me like that there is, the thing that I keep hearing here in this discussion as a non-medical person is time, and it seems like that we've had a whole lot of time that goes by trying to determine whether or not these reviews are going to be approved. But you're telling me it should be done in 3 days?
So what I will say is health insurance is only, what the state can regulate is only 17% of the market. So for example, for small businesses, it's only 700,000 people left in the state of Texas that are covered in the small business group market. So you're really talking about a small number of individuals relatively to the rest of the state when you're talking about 70% of people. If you're looking at the employer market, it's about a third of the employer market. 2/3 of the employer market is not handled by insurance. It's handled, for example, by a large employer, takes on those claims themselves. That's often called self-funded or ERISA exempt, and they are not a part of these pieces. Medicaid has its own requirements and timelines. Medicare has its own timelines and requirements. And as you guys have heard many times, there's a large number of people that are uninsured in Texas.
Okay.
So really, when you're talking about these timelines, you're talking about them applying to 17% of people.
Okay. Are there standards for the numbers of doctors that you are supposed to hire to perform these reviews?
They have to be licensed in the state of Texas to do this.
No, I'm talking about the numbers. The numbers of doctors?
Oh, no. You have to meet more outcomes on timelines versus the number of people you have to process them.
I see. Okay.
It's more of you have to hit the timelines.
Okay. All right, thank you.
Other questions, members? Yes. Representative Jones?
So, I remember back to when I was a baby lawyer and I used to do insurance defense and I represented insurance companies. And one of the things I noticed was that it was no, and basically people would get tired if there's pre-authorizations before claims are paid. And I was always just sort of confused that people pay their premiums and then they have to wait to decide if the same people they pay their premiums to are going to authorize whatever it is they need. And so if most of the pre-authorizations are granted eventually, and the people that are paying the premiums in good faith are trying to get access to medical care, it just seems like the insurance companies want to just sort of have their thumb on everything to decide whether somebody gets stuff. So it seems to me that this bill sort of gets rid of all of that for the most part. And so I think it's a good bill, even though I just heard of it. but I'm just frustrated.
Is there a question?
Yeah, so help me understand why you wanted more administrative stuff for you guys to look at when I think the whole purpose of this bill is to get rid of that so that the patients can have access to care quicker.
We don't want more administrative things to do, or work through on this. We are fine with the full medical license. We just want to make sure we can hire the physician that we're required to hire to have a full medical license. It's just a clarification.
Okay.
Other questions, members? Thank you.
Thank you.
Chair calls Sarah Lindley Bailey. And after that, we'll get a resource witness from the medical board. Sarah Lindley Bailey. Okay. Okay, do we have somebody, a resource witness from the medical board? If you'll state your name, who you represent, and your position on the issue, although I know you're neutral.
Yes. Good morning. I'm Stephen Carlton. I'm with the Texas Medical Board and the Executive Director. I'm here as a resource witness, neutral on the bill.
Okay. Members, any questions for the witness? I know several of you had questions about the licensure. Representative Collier.
Thank you, Madam Chair. I just want to get clarification. So right now, as Ms. Dudensing explained, that's not funny, I made a mistake. Oh, sorry. As she explained, a person who is practicing, or who is doing the utilization review, a physician, they cannot practice medicine full-time, or they can't practice medicine. They have to get a separate license called an administrative license. And that's something that was created by the Texas Medical Board.
I am not aware of a requirement that someone working for a health plan can only have an administrative license. There is an administrative license that someone may choose to get an administrative license versus a full license for a couple of different reasons. It may have to do with active practice. Maybe they haven't practiced in the last couple of years directly with patients. They may have some type of an impairment or had an illness or an accident that makes it impractical for them to practice medicine with patients, but they still want to use their medical knowledge in a way, and so they would have an administrative license. But again, staff has been looking since the comment was made. We can't find anything where the medical board or in statute that prohibits someone from having a full license and working for a health plan.
Okay. Okay. And so then, in terms of implementing the provisions of this bill, you understand it, and do you feel like you'll be able to, will you have any issues with this implementation?
So again, I've heard that there is a committee sub, as was mentioned. We haven't seen the language of that yet. The way that we understand the bill and the kind of how we would go about implementing it is that if there was a complaint that something was not approved, that the patient thinks should have been approved, it would go to TDI. TDI would look at it and determine whether or not that was a covered service under their health insurance. If it is a covered service, then it would come to us to review on whether or not, that there was some sort of arbitrary or no medical basis for denying that coverage or that procedure that should have been covered. The way we look at things right now in regular complaints, we look at whether or not it meets the standard of care. I think the language in this bill, again, talks about something being arbitrary or no medical basis. That's a little bit different than how we look at it right now. So I think as far as standardizing it, how we look at other complaints would be maybe preferable if it said it didn't meet the standard of care to not provide that service. But again, as it is right now, it would go to TDI, it would come to us if TDI determined that coverage, that procedure should have been covered, and then we would look to see whether or not it met there was an arbitrary or no medical basis to deny the coverage.
Okay, thank you.
Representative Alverson?
Thank you, Madam Chair. Brent, I appreciate you being here today. Thanks for being willing to kind of fill us in on this a little bit. So the bill, as I understand it, would essentially remove the administrative license issue. Do you see any issues with requiring a physician to have a full license as far as working with an I know we talked about you can't find any specific thing that says you have to have administrative license. The medical board doesn't have any issues granting a full license to somebody who's primarily doing prior authorization reviews or is serving as a medical director for an insurance company. There's no reason why they can't. Does a administrative license have to do to CME and ethics and stuff like that?
Yes, an administrative license still has to do their CMEs.
So is there a whole lot of difference between a full license and administrative license, or?
There's not any difference as far as, the way we look at it. Primarily the difference has to do with that active practice piece. So if someone has not been, kind of hands-on with a patient for an extended period of time and they apply to get a license with us, they may be easier for them to get an administrative license versus a full license.
Okay, so that makes sense. So what you're saying then is that, and maybe this is kind of how this is, I'm trying to reconcile everybody's testimony. So essentially, if you were looking to hire somebody that maybe hadn't practiced in a long time, that was just going to be not seeing patients but reviewing paper, PAs, then you may not need a full license. So you get an administrative license because you're not actually a practicing physician.
That's correct.
And so this would change that, but I guess to the author's intent, and I would certainly agree with this, if you're denying somebody access to care on the basis of medically necessary, you mentioned covered service, and I think it's important that everybody realizes that there's basically two steps. Is it covered by the plan? Because some things aren't, like cosmetic surgery, for example, is not typically covered by an insurance product. But then is it medically necessary? You may have a situation where somebody's trying to take a diabetes drug for weight loss, and that may not be medically necessary, whereas if they're taking a diabetes drug for diabetes, that could be very medically necessary.
Right.
And so what you're saying is that for that second piece, that's what the medical board is looking at. And the reason you're looking at that is because you want to make sure that approval or denial of medically necessary is actually in keeping with standards of practice and what you are generally charged with doing, which is making sure that doctors who are practicing medicine are practicing to a high ethical standard that is basically up to date with current research and current medical thinking, right? And so that's the whole point of the medical board, is you have all these doctors that are basically charged with making sure that Dr. X, who's out there practicing medicine by reviewing all of these PAs, is essentially up to speed and is not practicing medicine from 30 or 40 years ago.
That's correct. And also, as talked about earlier, the hypothetical situation of if it's a pediatrician that is denying something for neurosurgery or something. The way the medical board looks at it is when you have a full license, you're not restricted to only practicing certain types of medicine or some medicines in your specialty, but you're still held to the same standards. So if you're making those decisions as a pediatrician to deny something that is based in neurosurgery, you're going to be held to the standard of a neurosurgeon would be.
And just to be clear on the penalty side of this, because the enforcement mechanism for making sure that people are making medically appropriate decisions in approving or denying care, you guys are essentially the hammer. You essentially have the ability to come in and judge that the person who did the prior authorization failed to meet the standard of care. Denied medically appropriate care. The author indicated that would typically play out in a scenario where there was a patient harm that occurred. And I guess I wanted to see what your thoughts were as far as on the implementation side. So TDI is going to look at is going to look at it first and then send it to you guys. And what sort of actions can you or might you take? And can you tell us just briefly, how does that process play out once you receive a complaint? Let's say you receive a complaint for denial of care and there was a, alleged patient harm that occurred as a result of the delay?
So once it comes to the medical board, we would put it into our standard complaint review process. Fairly quickly, it's going to go to a couple of experts that are in that specialty to review that decision that was made.
Are those members of the medical board, or are those experts that the medical board utilizes that are outside? In other words, are they appointed members of the board, or are these physicians out in the community who are experts in their field?
They're experts that are out in the community. They're not employees of the medical board. And so they're actively practicing specialists in that area. And so we find someone that's not in the same geographic region as, where the complaint is originating from to make sure there's no types of conflict of interest. But we will get experts that are somewhere in the state and they'll take a look at it. If both those experts agree that there was a violation of the standard of care, then it will continue on with the complaint process and we'll have an informal settlement conference. You could potentially go to the State Office of Administrative Hearings. If for some reason there is a disagreement and one expert thinks there was a violation, the other one thinks there was not a violation, it'll go to a third as a tiebreaker.
Okay, and the penultimate sort of penalty in this is that you have the ability to suspend or revoke the physician's license, right?
That's correct. The way the current bill is written, revocation is possible and allowed.
And just to be clear, I mean, that essentially is how this process works for this piece of the gold carding thing, is that the doctor doing the reviews has to be licensed in the state of Texas. So in order for them to be able to do a prior authorization in the state of Texas at all, it has to be somebody who is a licensed physician, which means that if they exercise bad judgment and deny medically appropriate care, then you have the authority to pull their license.
That's
and then they can no longer serve in that function. So that's how this whole thing works, and that's why you guys are part of this process, right?
Yes, that's correct.
Okay, all right, thank you. I appreciate it, Brent. Thanks for being here today.
Other questions, members? Alrighty, thank you.
Thank you.
Is there anyone else wishing to testify?
There she is.
Okay. Sarah Lindley Bailey. Sarah Lindley Bailey.
She's coming up.
Hi, good morning, Madam Chair and honorable committee members. My name is Sarah Lindley Bailey, and I stand before you as a grieving mother and an activist for parental rights and medical freedoms in childhood cancer. I have a story to share, a story of my beloved 4-year-old.
Are you supporting the bill?
I am.
Okay.
And she's representing herself.
And you're representing yourself?
Yes,
Thank you.
thank you. So, long story short, we were denied care because of our insurance company. Once your child is diagnosed with cancer, you have minimal rights as a parent for treatment. The only approved hospital under our insurance was Shriners Children's Hospital. Back in 2019, they did not accept cancer patients. My little family suffered hours for waiting for approval. Medicaid was suggested if we divorced. We had to be divorced in order to get Medicaid, which denied us, which we didn't approve for because we were married, we owned a home, and we owned vehicles. We were also small business owners. We were denied a shunt surgery because insurance might not pay for it until she stopped breathing. Whenever you have a brain biopsy, hydrocephalus is very, very common. She experienced daily seizures multiple times a day. And seeing your child suffer in that way and not be able to do anything about it is the most heartbreaking ordeal that you can ever experience. We were also denied $1 million treatment for stem cell treatment for her cancer. We were denied very many things. We were denied blood cultures because of the hospital protocol and because insurance wouldn't pay for it. It led up to her brain, and we were on hospice shortly after. And then because we did not approve for Medicaid, I had to be the caregiver 24/7 for 3 weeks before we had to go up to the hospital again because she had a collapsed lung. This should not happen, and I fully support this bill. Thank you.
Questions, members? All righty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 4343? The chair recognizes Representative Alverson to close for Representative Bonin.
Thank you, Madam Chair, and it's an honor to pinch hit for my colleague who needs to get to an appropriations hearing. So I just want to clarify a couple of things on this administrative license in closing, and that is that this bill doesn't eliminate the administrative license. That's still available. And my understanding is that technically a medical director of an insurance company does need to have an administrative license, and this doesn't prevent that in any way, shape, or form. What it says is that the physician who is doing the prior authorization needs to be somebody who has current medical knowledge and is currently a practicing physician, so that we can make sure that the medical judgment that's being exercised is up to the same level of care and standard as what is out there in the community being practiced. And so to clarify, I know there's been a lot of back and forth, but in visiting with the author, we think that is essentially how all of these different comments are integrated. So nothing in this bill eliminates an administrative license, and nothing in this bill prevents a health plan from hiring a medical director with an administrative license. It just makes a requirement that a person performing a prior authorization have a full unrestricted license to practice. And with that, I'll take any questions that you have, and respectfully, we'll close.
Questions, members? All righty. If there's no objection, House Bill 4343 will be left pending. The chair hears no objection. House Bill 4343 is left pending without objection. The chair lays out House Bill 1349 and recognizes Representative Sherman to explain the bill.
Thank you, Chairwoman Click, and distinguished members of this committee. Thank you for the opportunity to lay out HB 1349. This bill will seek to restrict the catfish food label food service establishments to prohibit the mislabeling of various fish as American catfish and impose civil penalties for violations. Popular alternative to catfish in restaurants today is swai fish. It's imported from Vietnam, where farming practices do not meet our environmental and consumer safety standards. Swai is typically raised in crowded farms with few regulations of water quality, mercury levels, and other pollutants. By ensuring the proper labeling of these fish, we would support the Texas catfish farmers and certify that consumers are not purposely or inadvertently misled about the product they are consuming, allowing them to make knowledgeable choices about the food they choose to buy and consume. Thank you again, Chairwoman Click and members of the committee. I reserve my right to close.
Questions, members? Okay. Representative Sherman, I don't show anybody registered to testify. Is there anyone wishing to testify on, for, or against House Bill 1349? The chair hears none, and she recognizes Representative Sherman to close.
Thank you, Chairwoman Click. As several of you know, on this fine committee, this bill passed through the House last session and got stuck in the Senate. But we're back, and 2 days ago, well, April 11th, it wasn't 2 days ago, it was my mom's birthday, and this bill was very important to my mother, and she passed away on August 28th of last year, and would mean a great deal for those Texas catfish my family has a little over 200 acres in East Texas and on Cattle Lake, and, you know, raising catfish, even though I'm not a fisherman, I know what catfish tastes like, and Hattie Mae Sherman, you know, would be the namesake of this bill. So with that, I move close.
Righty, thank you.
Thank you.
Thanks, Carl.
If there's no objection, House Bill 1349 will be left pending. The chair hears no objection. House Bill 1349 is left pending without objection. The chair lays out House Bill 2495 and recognizes Representative Price to explain the bill.
Thank you, Chair Click and members of the committee for allowing me to bring up House Bill 2495. I know that I'll make this brief. We have a resource witness that is going to attend jury duty. House Bill 2495 is not a scope bill. It's a cleanup bill regarding TDLR's licensure athletic trainers. House Bill 2495 would amend the statutory language for the athletic training licensure process to be consistent with statutory authority and processes currently in place as at the Texas Department of Licensing and Regulation. When the program transferred to TDLR from the Department of State Health Services, some statutes were not updated to reflect differences in the administration. The bill would also remove outdated language related to licensure qualifications and processes. In 2015, SB 202 by Senator Nelson moved athletic training licensure from DSHS to TDLR as part of DISH's sunset review. However, SB 202 did not conform to TDLR's licensure process. For instance, DISH's had a seal, but TDLR does not have a seal. There are other cleanup changes in the bill to accurately reflect TDLR's actual licensure process of athletic trainers. TDLR recognizes broad categories of continuing education opportunities, but it does not approve individual courses or identify continuing education providers. The bill removes requirements related to keeping seals and rosters since TDLR already has a search function for licensees and does not have seals for individual programs within the agency. Additionally, the bill removes a reference to a degree that is no longer offered as a means to licensure and conflicting language regarding out-of-state application requirements. These are cleanup measures that will improve transparency to licensees and expectations for the program's administration. Before you is a non-Ledge Council draft that we filed in the interest of time. I will have a committee substitute that will be substantially the same as the language before you, but with the draft council number. I'm happy to answer any questions. Would like the opportunity to close on the bill.
Questions, members? Okay, I'm not showing anybody registered to testify. Is there anyone wishing to testify on for or against House Bill 2495? Chair recognizes Representative Price to close.
Thank you, Madam Chair. This is a non-substantive cleanup bill. I appreciate the committee's consideration and would love to have the bill sent to local and consent calendars. With that, I close.
If there's no objection, House Bill 2495 will be left pending. The chair hears no objection. House Bill 2495 is left pending without objection. The chair lays out House Bill 1373 and recognizes Representative Price to explain the bill for Representative Dean.
Do you have the committee substitute? No. Okay. Thank you, Chair Click. I'm happy to lay this out for Representative Dean. In 2017, Representative Dean served on House Select Committee on Opioids and Substance Abuse. At that time, his hometown of Longview had the unenviable distinction of being in the top 20 worst cities for prescription opioid misuse. Sadly, as we all know, the problem has only gotten worse. While this body has taken many strong steps to prevent opioids abuse and addiction, a large vulnerability remains. What to do with unused opioids you have already been prescribed. This is a huge back-end supply of opioids that exists and have already been dispensed, just sitting in medicine cabinets, tempting or endangering families every day, or worse, being diverted or sold to addicts. There are some alarming statistics. 80% of heroin addicts first misuse prescription opioids. 70% of abused medications are taken from household medicine cabinets. 20% of Texas high school students admit to having taken someone else's prescription. And according to the National Institute of Drug Abuse, taking someone else's prescription medicine is a leading method of misuse, eventually leading to abuse and sometimes addiction. For patients who want to properly dispose of opioids or other pharmaceuticals, it's difficult to know how to do that. Federal regulations say that only a pharmacy or law enforcement can handle someone else's prescriptions once they've been dispensed. That limits where these take-back options can be and how they can be administered. Texas does participate in the National Drug Take-Back Days, but these are only held twice a year. While these are good, they're insufficient and can encourage stockpiling of up to 6 months or longer. Some private pharmacies have invested in drug take-back kiosks on their own, and while we applaud these efforts, they tend to be located in urban, highly trafficked areas, not in smaller rural communities like his or mine. In 2019, after Representative Dean's time on the Select Committee on Opioids, he introduced 2 bills aiming at increasing the number of drug take-back options and locations. While the House passed HB 2088 to provide a piece of paper talking about the importance of drug take-backs with every opioid prescription, the stronger legislation to increase the number of physical take-back options was met with concerns over funding. In 2021, Texas established the Opioid Council and the Opioid Global Settlement Fund, providing much-needed funds to support opioid abuse prevention and treatment. In 2022, Texas received $133 million, and in total is expected to receive $1.6 billion over the next 18 years. House Bill 1373 creates a pilot program for a statewide drug disposal program to be housed at the Texas Board of Pharmacy. The program would allow the state to reimburse retail and hospital pharmacies for the purchase of safe disposal receptacles and the disposal of the medications for 2 years. At the end of the 2-year pilot, there will be a report to determine the effectiveness of the program and whether there is ongoing need for state support or if the program can sustain itself after the initial startup. The bill would allow for the installation of approximately 1,000 drug take-back kiosks, with priority going to rural and other underserved areas with less access to consumer drug take-back sites. The bill also allows for other options such as mail-back pouches, which may help homebound or less mobile Texans. The cost is about $6 million over the biennium. SB 1827 from the 87th session established the framework for how money could be accessed from the opioid fund. SB 1827 authorizes the funds to support efforts to prevent or reduce deaths from opioid overdoses or other opioid-related harms. Drug disposal programs are identified as a core prevention strategy in settlement documents. Currently, 10 other states have established statewide drug disposal or take-back programs. There will be a committee substitute that makes technical corrections to conform with federal regulations. It will clarify all prescription drugs are eligible for disposal, not just controlled substances. That is a change that needs to be made because no one knows what goes into the disposal kiosk, so there's no way to enforce that it is only opioids or controlled substances. The sub will also clarify the alternative options, such as mailbacks, to make the fiscal note more determinable and workable. The intention was never to buy an envelope for every prescription in Texas, and the sub will clarify that. I'm happy to answer or attempt to answer any questions on Representative Dean's bill if you have them. Otherwise, I'd love the opportunity to close.
Questions, members? All righty. Do you need the resource witness?
I don't.
Okay, the chair calls Kristen Allred. Kristen Allred. And Kristen, I show you registered for Stericycle and yourself, and that you are supportive of the bill. Is that correct?
Correct.
Okay, you can begin your testimony.
Good morning, everyone. Thank you for the opportunity to speak to you today in favor of this bill. My name is Dr. Kristen Aldred. I'm Director of Government Affairs at Stericycle. Stericycle provides compliance-based solutions for regulated wastes that protect people, promote health, and safeguard the environment. We support healthcare by managing infectious, pharmaceutical, and similar regulated wastes, and offer services to support drug take-back activities across the nation. Drug take-back programs are an important prevention strategy. My interest in the topic stems from witnessing the terrible impact opioid diversion can have on a family after my grandfather died in home hospice at a time before drug take-back programs existed. This experience eventually led me to conduct dissertation research on drug disposal behavior and later joined Stericycle to help expand access to drug take-back. People have gotten the message that they shouldn't put drugs in the trash or wash them down the sink. but they often aren't sure where to go, so they hold on to them at home, or they keep them in the trunk of their car or carry them with them. Drug take-back sites are recognized as the best practice for consumer drug disposal. For example, the FDA states that take-back events and permanent collection sites are, quote, the best way to safely dispose of unused or expired prescription and non-prescription medicines. Last October, in just 4 hours, more than 46,000 pounds of pharmaceuticals were collected in Texas on the National Drug Take-Back Day. Expanding permanent collection locations will help ensure that people can quickly find a convenient drop-off site year-round rather than holding on to those medications. Importantly, convenience is about more than distance. Research has shown that people are more likely to use a kiosk at a place they visit regularly, and they may not be comfortable participating in take-back events managed by law enforcement. A major barrier to establishing a take-back location is the one-time cost to purchase and install a kiosk, and that's a piece of equipment that will last for several years. Funding will help overcome this barrier and result in more permanent collection sites across the state. Thank you very much for working on this important issue and for the opportunity to speak with you today.
Representative Collier.
Thank you, Madam Chair. So you, says you're representing Stericycle.
Mm-hmm.
Do they own these types of disposable containers?
Yes.
And so what states are you guys in?
We're in every state.
You're in Texas too?
Yeah.
Okay. And so what is happening in Texas now that impacts, like, is there something that's going on that your business is impacted in by the current law?
So in Texas right now, there are, I think as the representative mentioned, there are private sites, retail pharmacies that have decided to go ahead and do this on their own. They're at a small percentage of their locations, so that leaves a lot of gaps in terms of rural areas or places that are underserved, or a place where you might have quite a number of hospitals and pharmacies, but relatively few kiosks compared to that. And the behavioral research shows that the more something is sort of part of somebody's routine, or they're familiar with the location, they're comfortable going there, the more likely they are going to use that kiosk. So in other words, the more you have in different places, in hospitals where people go, in the pharmacies that they're familiar with, the more likely people are.
So you could actually do this now?
Yes.
The program that's in this bill?
Yes.
But they're just not taking advantage of it?
Typically, if you have an independent pharmacy or a hospital, this is an expense for them that they may not be able to.
Why? Because they have to pay for your disposable kiosk?
They have to kind
How
of.
much do your kiosks cost?
It's about $2,000 to.
For one?
For one, to be installed.
And so you pick it up and then you dispose of it properly?
So the container that I just mentioned, that's a steel container. The DEA requires that be bolted to the ground or to a wall. Inside of that is a box and a liner. That's all, lots of regulations around that as well. When that's full, the pharmacy takes it out and it can actually be sent via common carrier, and all of those drugs are incinerated.
So the proposal, the pilot program that's under here, is it your understanding that they would have pharmacies would apply to have a license or permit to have one of those types of kiosks on their premises?
Mm-hmm. So they would need to change their registration with the DEA, which is a simple process to become a collector. And then the idea here is that they would apply to the state to get reimbursed to do this. And it's something that has been done in a number of other states. Colorado, for example, has a program where they've installed kiosks around the state. And I think that's been around for about 3 or 4 years, and the state's been supporting that.
And the state pays for it?
Mm-hmm.
Okay, and so the state pays the pharmacy or pays your company?
I'm not sure. I can find out.
Okay. So then if the kiosk, are they inside the pharmacy or are they outside?
They're inside, and there are rules around that too. So they have to be within the line of sight of the pharmacy. So somebody who's responsible for that. In hospitals, they have a little more flexibility. Can't be in an emergency room. Still has to be somewhere where somebody can see it and supervise it.
Yes, because I would be concerned about theft. Is that why you do it like that?
That's, yeah, those are all
One of the
EA
reasons.
rules. When they started this, they put a lot of rules around where they can be, how the kiosks are installed. They have typically dual locks on the main door where the drugs come out, and another lock on the small door where drugs go in. And if a pharmacy closes, like if you have a 24-hour pharmacy, when the pharmacist goes home and the pharmacy itself is closed, they lock the kiosk.
So right now, you can still do this, and it sounds like not a lot of pharmacies are taking advantage of the program. When they do this, it says that it would be located in a rural or underserved area the board designates. So are they looking at, is it your understanding that they would be looking at the crime rate in the particular area?
You could look at a number of things. You could use geographic information systems to overlay different demographics and locations of pharmacies and hospitals, and time, it takes for people to get different places and kind of do that. I think it's Missouri that's done an analysis like that. They've mapped everything out.
Okay, and so then going back to your business currently, Stericycle, do you, it's $2,000 for the kiosk, and then is there a maintenance ongoing cost?
Each box. So when you fill up that box, it's the cost of the materials, the shipping there, the shipping back, and the incineration. And it really depends on how busy it is. So if it's a rural hospital, they might have one box every couple of months. If it's an urban pharmacy that's very busy, they could have one or two a week.
And so that's a cost that's on top of the actual kiosk?
That's the ongoing cost. Mm-hmm.
Do you know how much that is?
It's about $100 a box.
A box. And that's what it would be here in Texas? Are you?
Roughly, yeah.
Are you the only kiosk in Texas, or is there another business?
No, there are several companies around the country that are able to do this. And I think, as I mentioned, I became interested in this personally on my own.
But my question is, who's the other business in Texas?
I don't know all of them.
But there's more in Texas?
Yes.
Okay, thank you.
Mm-hmm.
Other questions, members? Alrighty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 1373? Chair recognizes Representative Price to close.
Thank you, Madam Chair. Representative Collier, just reading the bill, looks like the reimbursement goes to the pharmacy that is participating, for the cost of the installation, the acquisition, installation of the box. I think it's pretty clear what Representative Dean is trying to accomplish with the bill, and I appreciate the opportunity laid out. Close.
If there's no objection, House Bill 1373 is left pending. The chair hears no objection. House Bill 1373 is left pending without objection. The chair lays out House Bill 3236 and recognizes Representative Herrero to explain the bill.
Thank you. Good morning, Madam Chair, members of the committee. Thank you for allowing me to explain House Bill 3236 as drafted and before you. This bill seeks to have a member of the Texas Radiation Advisory Board, specifically the member who represents the agriculture industry, to be a person licensed by the State Board of Veterinary Examiners. We intend to file a committee substitute. We've gotten some concerns from that industry letting us know that they would rather not have it be specific. And so instead, we'd like to submit a committee substitute that adds a 19th member to the Radiation Advisory Board that is licensed by the State Board of Veterinary Examiners. And with that, I'd like to reserve the right to close if there are no questions.
Questions, members?
Thank you.
Chair calls Anella Stanford. I show you registered as Anella Stanford, and you're representing the Texas Veterinary Medical Association and yourself, is that correct? And you're for the bill?
Yes, ma'am.
Okay, please begin.
Good morning, Madam Chairman and members. My name is Dr. Nella Stanford. I'm a veterinarian practicing here in Austin, Texas, and I am speaking in favor of House Bill 3236 on behalf of the Texas Veterinary Medical Association, a professional trade association representing the interests of more than 13,000 Texas veterinarians. The use of radiation in veterinary medicine is vital to diagnosing and treating numerous diseases for a variety of species. This use of radiation is very different than the way it is used in human health care. Veterinarians frequently use mobile radiation units to perform examinations on farms or ranches, as well as in a clinical setting, versus in human health care, it is generally stationary in a clinical setting. Additionally, our patients' size, temperament, and anatomy present unique challenges to performing an exam that human practitioners do not have to deal with. Taking an x-ray on a quarter horse in the pasture to check for laminitis is very different from a Labrador retriever with possible heart failure in the clinic. Rules regulating the use of radiation for veterinary medicine should be made with these challenges in mind to ensure that veterinarians are not subjected to regulations that are impossible for us to comply with. An example of this would be requiring all personnel be out of the room or 6 feet away when any x-rays are taken. Simply impossible for most of our patients that require hands-on restraint. If that was to be the case, every single patient we take x-rays on would have to have full sedation or anesthesia, which could cause a safety risk for those patients. It's simply not safe and would severely hinder my daily job if such a rule would apply. That's just an example that I've heard proposed in other states. As a veterinarian, I was somewhat surprised that our profession, which utilizes radiation as much as we do, is not guaranteed representation on the board that regulates it. While there have been veterinarians on the board in the past who represent the agriculture sector as a whole, I'm concerned about rules that might be adopted during times in which the seat is not occupied by a veterinarian. The committee substitute would address that issue while also ensuring that other agricultural interests are also represented. That concludes my testimony. Thank you. I'm happy to answer any questions.
Questions, members? Thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 3236? Chair recognizes Representative Ferraro to close.
I close. Thank you, Madam.
If there's no objection, House Bill 3236 will be left pending. The chair hears no objection. House Bill 3236 is left pending without objection. The chair lays out House Bill 4059 and recognizes Representative King to explain the bill.
Thank you, Madam Chair, members, for the opportunity to lay out House Bill 4059. My history with bills like this goes back to 2013 when I lost my mother to ovarian cancer. Many of you have been down this road with me, and you know I file a bill every session to promote cancer awareness and particularly women's health. In 2013, when my mother lost her battle, our friend and colleague, Kyle Casal, lost his mother to the same disease at almost the same time. In response to that, Representative Casal and I co-founded the KK125 Ovarian Cancer Research Foundation. The purpose of the foundation has been to promote awareness, encourage early detection, fight for patients' advocacy rights, and something that was central to our mission in 2015 was the Right to Try Act. The Right to Try Act allows patients who have a terminally ill diagnosis the opportunity to use experimental treatments that could be their best chance for survival, but these treatments may not have been approved by the FDA. Give you a great example of this. Before 2015, when my mother was going through her battle against ovarian cancer, We've been treating and curing breast cancer in this country for years successfully. But before the Right to Try law passed, her doctor could not prescribe her a treatment that was FDA approved for breast cancer because it wasn't FDA approved for ovarian cancer. Maybe it worked, maybe it wouldn't, but she should have had the ability to try that treatment. She was denied that. So in 2015, my friend Kyle Casal authored the Right to Try Act, and I was a proud co-author, and we got it through the House. House Bill 4059 is just another tool built off the Right to Try Act for the purpose of helping those in terminal or life-threatening illnesses. The Right to Try for Individual Treatment Act, as we're now calling House Bill 4059, is designed for patients with rare diseases where treatments are designed for an individual patient using his or her own genetics. 10 years ago, members, when we started down this path, nobody had ever heard the term immunotherapy. I'm proud to say the work the KK125 Ovarian Cancer organization has done, and the money we've raised has promoted things like immunotherapy. It's promoted technologies such as liquid biopsies. None of these things existed 10 years ago. That's the reason for House Bill 4059, to just build off the new technologies that exist today that did not exist in 2015. House Bill 4059 would extend benefits of the original Right to Try to these patients, establishing a pathway by which patients' rare diseases may seek personalized treatments developed in federally approved facilities. House Bill 4059 includes safeguards for insurance companies, patients, and doctors, ensuring that the program is optional for all involved, but would be allowed under state law. That's what it does. We have several witnesses here. I'll be glad to try to answer questions. I think the witnesses might be better prepared for that. With that, I would reserve my right to close. Thank you.
No questions? Okay, we'll proceed to testimony. Thank you. The chair calls up Hannah Lowe.
Turn your microphone on.
Good morning.
Good morning.
Good morning. Chairwoman
Just to
Glick.
confirm, your name is Hannah Lowe, is that correct?
Yes.
You're for the bill?
Yes.
And you're with the CMD Research Foundation and yourself, is that correct?
Yes.
You may proceed.
Thank you.
You're welcome.
Thank you, Chairwoman Click, Vice Chairwoman Campos, and members of this committee. Thank you for having me here today. My name is Hannah Lowe. I am the mother of 2 boys, and I am here to lend my testimony in favor of House Bill 4059, Right to Try for Individualized Treatments, on behalf of families like mine facing rare diseases that are currently untreatable and incurable. I'm honored to be able to share the story of my son, Austin, and how his battle with his rare disease has led us down the path of medical research and opened my eyes to the urgent need for new pathways to treatment for patients that have no other options. Austin was born in August of 2019, and as far as we knew, he was a typical little baby. Unfortunately, at 5 months old, he had not gained enough weight, and the doctors admitted him to Texas Children's Hospital, which fortunately for us is right in our backyard of Houston, a world-class hospital. They ran a battery of tests over a number of weeks trying to figure out why he wouldn't gain any weight, and everything came back clear until his whole exome DNA sequence came back and revealed that he has a rare and fatal form of childhood muscular dystrophy called LCMD. There are no treatments and no cures. They told us there was nothing to be done except for take him home and love him for the time that we would have left, as our seemingly healthy child would likely die from a heart attack or respiratory illness. And of course, we were and are still devastated by this news. We didn't give up hope, however. After hours of Zoom meetings with medical professionals, researchers, and other rare disease families around the world, we found that we could help push medical research forward on behalf of people like Austin. Of course, developing new medical treatments is not easy, cheap, or quick, and this is why we need your help in creating laws such as HB 4059 that would expedite treatments, with appropriate safety measures, of course, for patients who have no other options. Under the current regulatory framework, The process for getting new treatments into patients is long, and this is time that we do not have. Respectfully, biotech and pharma companies are not incentivized to create new treatments for such rare diseases where the patient population is so small that commercialization is highly, highly unlikely. So it falls to the families and nonprofit organizations to scrape together the money to push for these new treatments just through pure grit and determination and love and lots of coffee. We are not asking for a handout. We are asking for laws like HB 4059 that would allow medical treatments to be developed faster with appropriate safety and efficacy measures and under physician care and guidance for people for whom there are no treatments and no cures. Please help us fight for Austin, for those with LCMD, and for the millions of others facing incurable and untreatable conditions. Thank you for your support.
Thank you, Ms. Lowe, for your testimony. Any questions? Representative Collier?
Okay, you said Aiden?
Austin.
Austin is your
Yeah,
son?
yeah.
He's still here with us?
Yes, he's 3.
Oh, that's wonderful. Praise the Lord. So what you're asking is that if there's current guideline treatment protocols that are in place for one condition, and it may also help the rare condition that your son has, you want to be able to allow the doctor or healthcare providers to use that protocol or that medicine?
Well, I believe, and the experts can correct me if I'm wrong, that might be under the current right to try legislation. And this would be an individualized treatment developed specifically for a person's genetic condition.
Okay.
So often these treatments might help one or a few people, but are not widely usable.
And you're willing to, if the law allowed it, if there was no health insurance, you're willing to scrape and find the money to cover these costs?
Yes, we have, we do golf tournaments and bake sales. And
Right.
our friends and our family come forward to support us.
Okay, perfect. Thank you so much. And I wish Austin well. And you're.
Thank you so much.
Thank you. Members, any questions? Representative Jones?
So right now, if there's some treatment that you and your family decide is best for Austin, you're not allowed to use it? Is that, or the doctor's not allowed to perform it?
So right now, there are no treatments or cures. If one were to be developed, it would have to go through the full FDA regulatory approval process through clinical trials, and it's just a multi-year, could be decade-long procedure, and that's just time we don't have.
So this would be like an end run to FDA approval?
I believe.
Or I should say work around.
I will let the expert who
Okay.
drafted this legislation answer that, yeah.
Well, thank you for answering my question, and I'm thankful that Austin is still around, and I hope that God continues to bless you and your family in figuring out how to have him have what he needs medically.
Thank you so much.
You're welcome.
Thank you, Representative. Representative Smith? No questions? Okay,
Thank you.
that'll be it. Thank you. The chair calls up Sarah Lindley Bailey.
Good morning.
Ms. Bailey, I see that you registered at Sarah Lindley Bailey. You're here for the bill and on behalf of yourself. Is that correct?
Yes, ma'am.
Thank you.
Thank you so very much. My name is Sarah Lindley Bailey. I am a grieving mother who lost her 4-year-old to very minimal rights. Once your child is diagnosed with cancer, you have very little rights. We flew to Arizona. I did not want to do chemo because I've seen so many loved ones die from those procedures. We flew to Arizona trying to get more natural, holistic treatments. Once we were there, the doctor said, I cannot touch your child without the okay of an oncologist or I would lose my medical license. That's not okay. It should be individualized to each parent's concern. And genetic markers, I agree 100%, because everyone's genes are different. The biopsy could never tell me if it was genetic or not. because we had 2 different biopsies. We were at Texas Children's. They wanted to do one procedure for chemo regimen that killed and stopped treatments for adults because everyone in that study died. I did not want to put my child through that, so we went to MD Anderson, where there was a more successful rate for the rare type of brain cancer that she had, which is ATRT. ATRT is extremely rare. Only 30 children are diagnosed in the US a year. I found 5 other families in the greater Houston area. Something has to change. I get calls all around the nation regarding medical kidnapping. In Texas, a family went all the way up to Michigan for a family holiday, and the child was throwing up. They were medically kidnapped because he was clear of cancer, but they wanted to continue doing chemo treatments. How is that America? Things need to change, and I fully support 4059.
Any questions, members?
Thank you.
Thank you, ma'am. The chair calls David Bells.
Hello. Thank you, Madam Chair and members. My name is David Bales. At this time, we oppose the bill.
Mr. Bells?
Yes,
I just
ma'am.
want to confirm that you are here on behalf of yourself and Texas for Cures.
Yes, ma'am. We're an all-volunteer nonprofit. We've been in operation for 15 years.
And you're against the bill, is that correct?
Ma'am?
You're against the bill,
At
is
this
that
point in
correct?
time,
Thank
number one, we feel like federal law supersedes state law. We have worked in the past with Representative Parker on House Bill 810. We fully support stem cell research, regenerative medicine. We think it's the new frontier, immunotherapy. We empathize with anyone that's trying to find a cure or extend their life for someone they love. However, as a result of House Bill 810, stem cell clinics across the state have proliferated incredibly in the last 5 years. There was a chiropractor in Brazoria County that gave unproven stem cell treatments to 7 patients, and they all went to the hospital and they almost died. One amendment we added with Representative Parker in the past was for any institutional review board that's working and giving stem cell treatments to patients, they need to report annually to the medical board. I have filed an open record request with the
Mr.
medical
Bells,
board.
can you please stick to your statements on this in particular bill?
Okay, well, right here it says, an institutional review board overseeing investigational stem cell treatment shall keep a record on each person to whom a physician administers the treatment and document in the record the provision of each treatment and the effects of the treatment on the person throughout the period the treatment is administered to this person. So we just feel like any doctor that's giving stem cell treatments to any patient needs to follow this, and we have not seen very many physicians that are reporting. So again, we feel like the federal law supersedes state law, and we don't think there's really a need for this law.
Members, are there any questions? Thank you, sir, for your
All right,
testimony.
thank you.
The chair calls Kimberly Moores.
Good morning.
Hello, ma'am. Just to confirm, you're Kimberly Moores. You're here on behalf of yourself, and you're for the bill. Is that correct?
Understood. My name is Kimberly Tycho Moyers. I'm a United States Navy veteran, and I'm here to tell you and stand in front of you and tell you experimental medicine works. And the DOD, which is the federal government, does approve it for us veterans. If you want to see it, I'm standing before you. When I was in the Navy, I was hit pretty hard. I had an amazing chain of command, and they put me in front of several foundations in partnership with the Department of Defense that instead of amputating my legs, I got to keep them. It was a long, arduous process. It took 7 years, but I have my life back, and I just really would like you to consider this bill. If the DOD does it, and I fought for the freedom of the great people of the United States of America, please give it to Texas. Thank you.
One moment. Do y'all have any questions?
Any questions?
No
Wanna see?
questions. Thank you, ma'am. Thank you for being here.
All right, thank you.
Welcome. The chair calls Naomi Lopez. Ms. Lopez, thank you for being here. And just to confirm, you are Naomi Lopez. You're here on behalf of the Coldwater Institute and you're for the bill, is that correct?
That is correct.
Thank you, ma'am. You may proceed.
Good morning, Chair Click, Vice Chair Campos, and esteemed members of the committee. My name is Naomi Lopez, and I serve as the Vice President of Healthcare Policy at the Goldwater Institute, which is based in Phoenix, Arizona. As a native San Antonian, I'm honored to be back home and grateful for the opportunity to present my testimony in favor of House Bill 4059 on the critical issue of protecting the right to try to save one's life without first having to beg the federal government for permission to do so. Imagine a scenario where a revolutionary treatment for a rare disease exists, tailored to your unique genetic profile, offering a glimmer of hope. However, you are unable to access it despite your own doctor's recommendations, all due to outdated federal regulations that hinder the rapid approval of such groundbreaking genetic treatments. Today, Texas has a golden opportunity to spearhead change and save lives by advocating for a new treatment pathway called Right to Try for Individualized Treatments. Texas has already demonstrated leadership with its original Right to Try law enacted in 2015, when it granted patients the right to seek treatments that were deemed safe enough for clinical trials, but were still waiting for final FDA approval. This law was passed in 41 states and signed into federal law in 2018. It's not only working, it's saving lives, and it is accelerating the clinical development process. There is an important opportunity to provide a new pathway that would accommodate today's rapid advancements in medicine, such as gene and cellular therapies, which are not covered under the original Right to Try law. This is where Right to Try for Individualized Treatments, or Right to Try 2.0, comes in. The proposal does not alter the functioning or future success of the original Right to Try law. Instead, it establishes a new, safe, and physician-directed pathway for patients with rare and ultra-rare diseases who lack treatment options in clinical trials and whose doctor is recommending a personalized treatment. Under the proposed legislation, patients may seek the recommended treatment from a facility operating under a current federal-wide assurance, which ensures compliance with federal laws and regulations governing human subjects protection and research. This well-established system offers important protections and safeguards for patients. Texas can continue to lead the nation in providing the right treatment to the right patient at the right time. House Bill 4059 not only removes government red tape limiting patients who are under their doctor's care from seeking 21st century treatment options, patient safety and informed consent are ensured, and it's done so without additional taxpayer investment. You can do it today. Texas lawmakers possess the authority and legislative vehicle to harness the potential of today's medical innovations to further benefit patients. Thank you for your consideration and support of House Bill 4059. I'm happy to take questions.
Thank you. Are there any questions? Thank you, ma'am, for your testimony.
Thank you.
Is there anyone else here to testify on or behalf HB 4059? The chair recognizes Representative King to close.
Thank you. Thank you, Madam Chair. Thank you, members, for listening to this important piece of legislation. As the testimony proved out, this is just an extension of what we passed in 2015. Technology changes. It's time to update our law and keep promoting the healthcare and right to try in the state of Texas. I would appreciate your favorable consideration, and Madam Chair, if you chose to vote this bill out today, I would appreciate it. With that, I close.
If there is no objection, HB 4059 will be left pending. The chair hears no objection. HB 4059 is left pending without objection.
The chair lays out House Bill 638 and recognizes Representative Toth to explain the bill.
Thank you, Madam Chair and members. HB 638 expands the Right to Try Act that was passed by the legislature in 2015. I do have a committee sub.
We don't have.
You don't have it?
Just explain what it is that
Yes,
you want to
ma'am.
do in the sub, but we don't.
I did make some lengthy changes that will be reflected in the committee sub after having much counsel with Dr. Bonin. And we will continue to make sure and strengthen the bill with some consulting with Dr. Oliverson as well. But the other reason was to make this language more closely aligned with Senator Parker's almost identical language in the Senate. So one thing you'll notice is that we have named the House bill Mary Lou after a hometown hero in the Woodlands who tragically passed away. She was a beloved member of our community, a hometown hero, and we miss her deeply. And you're going to get to hear from her daughter about this on this bill as well. This bill would give hope to patients who have exhausted existing medications and otherwise have no hope. I'm happy to answer any questions.
Questions, members? Okay, we will reserve your right to close and.
Thank you,
begin
Madam
public
Chair.
Testimony. Chair calls Marlise Ledbetter. Up next will be David Bales. I have your name as Marlise
Yes, ma'am.
Ledbetter,
Yes, ma'am.
and you're representing yourself,
I am.
and you're for the bill, is that correct?
I am. This is
Okay,
our bill.
please
our
begin
family
your
bill.
testimony.
To the esteemed members of the committee, thank you for allowing me to speak on why HB 638 was created, Mary Lou's Law. My name is Marlise Fitch Ledbetter, a patient-first advocate for medical care, and I'm the oldest of 4 girls who all witnessed a horrific story play out. Never did I think I'd be fighting these odds for my own mother, who we lost to medical malfeasance. On October 2nd, 2021, my mother took her last breath under forced comfort care to end her life. And it was the last day of an only week-long struggle for survival against a broken medical system with no rights to try. My mother, Mary Lou Fitch, as Representative Toth said, was an awarded hometown hero in the Woodlands. Her entire life was dedicated to giving back selflessly to a myriad of organizations and public causes. Like so many, my parents got sick during the pandemic, and we had expert home care through my connections in functional health. We had heard through public service announcements that monoclonal antibodies were helping people, and we didn't want to take any chances. Only my mom was one of the small percentages that had life-threatening adverse reactions, which are impossible to report, by the way. At the hospital, there was only one option: remdesivir, powerful sedatives, painkillers, and likely a ventilator. We were explaining that she had a severe reaction, but they were telling us they had never seen that and that it was just the virus. Every day, telling them what medications we would not allow her to be on and pushing ones that we said no time and time again. And discussing end-of-life care when she just got there to a reaction that they seemed to not agree existed. We all started reaching out to the community, asking questions, and yes, indeed, people were having severe reactions and going to the hospital, but unfortunately, most of the stories we had heard, they had not survived. We fought against administration, continually questioning them for protocols that I had set in place. Every day we fought to be able to see her when the administration told us it was not possible no matter what, so we got a judge's order. And what we saw did not make sense. No to IV vitamins, no to breathing treatments for what was now pneumonia, no proning, no getting her up and moving her around, which is a very real practice when you have pneumonia. No second opinions from experts that have been successful. No to outside doctor specialists, even with her own medical history. No outside transfers, even to facilities that we found would take her. No to certain medicines, even with clinical data that were FDA approved. Medicines that seemed to make it harder for her to breathe, and even doctors that reached out to us were confused as to why they were using certain medications. And the respiratory specialists let us know that they would not allow her to do her job, and she's not there anymore. She ended up having so much trauma that she left the industry. That's not the protocol, they said. That's all we heard was it's not the protocol. This is not medicine, this is murder. Her story is not even the worst. We shared our experience online and hundreds of people reached out to us. Horrific battles, mostly lost battles against what seemed to be a solution to everyone the exact same. Since there is only one, a handful of options for a life-threatening care. And even nurses reached out to us letting them know that they were complacent and leaving their jobs, and most of the nurses that cared for ours mother were contract nurses. How could this be? How could we have turned medicine into this? My father was treated by the FDA-approved drugs and was better within 2 days, and we think, could she have been the same? My mom always said, if you don't like something, that how it's run, to change the law and use your vote, so here we are, with a bill in her name that is hopefully going to change the way that patients receive care in their most dire need. This bill would offer the right to try and the right to try alternatives. We are in a battle against evil, and I hope you fight with us to make this bill a law. Thank you.
Questions, members? Thank you. Up next is David Bales, followed by Michelle Wells. I show your name is David Bales, and you're representing Texans for Stem Cell Research.
Yes, ma'am.
And Texas for Cures and yourself, is that correct?
Yes, ma'am.
And you're against the bill?
Yes.
Okay, please begin your testimony.
Again, like I said earlier, we strongly support stem cell research, regenerative medicine, immunotherapy. From the very beginning, our medical advisory committee, which consists of people like the late James Willerson, who did the very first clinical trial in the world administering stem cells to heart patients, they all, without fail, said they believed any patient trying an unproven stem cell treatment, it should be in an FDA phase 2 trial that shows efficacy. Phase 1 is a safety trial, maybe 10 or 12 patients. Make sure the drug is safe. Then you go into phase 2. We still feel that same way. And as a result of House Bill 810 4 or 5 years ago, again, there's been stem cell clinics proliferate like crazy in the state. In your packet that I gave you, some of the people in Brazoria County, they paid $17,000 for an unproven stem cell treatment. Many of them got sepsis. An 88-year-old woman had to be flown to Houston Medical Center.
Mr. Bales, can
Yes,
you
ma'am.
explain to me how that pertains to this bill?
Well, because we think by having the right to try an unproven drug, like what this bill says, I think you're opening up a situation where more and more stem cell clinics are going to charge people for something that hasn't been proven to work. So, again, we added that amendment last session with Representative Parker that requires these physicians to report the outcomes. We think that's a wonderful idea. If somebody's going to try an unproven stem cell treatment, they should be able to go to the Texas Medical Board and find out if it worked before or what the outcomes were. So we're here to protect patients. We're here to further stem cell research, immunotherapy, and regenerative medicine. We just think it ought to be done in a safe way to protect the patients.
Questions, members? Thank you.
Thank you for your time.
Michelle Wells. Up next will be Sarah Lindley Bailey. Michelle Wells.
She needs to come up.
You need to come up. We show your name as Michelle Wells. You're representing yourself and you're for the bill. Is that correct?
Yes. Oh my God, I'm so nervous. I am
Was that
Michelle
correct?
Wells. I support the bill.
Okay, thank you. Sarah Lindley Bailey. Next on deck will be Kimberly Barber. We show you as Sarah Lindley Bailey. You're representing yourself and you're for the bill. Is that correct?
I am.
Thank you. Please
Thank you.
begin.
Thank you so very much for your time. I fully support House Bill number 638, Mary Lou's Law. Amendment rights try. I was told constantly I did not have a choice in the matter. Believe it or not, lots of chemo drugs are experimental. They are not FDA approved. I actually went to MD Anderson because I liked the stem cell treatment better than the trial that killed adults. And that was what they were trying to do for my baby. I'm going off script right now because I am mad. I am furious because parents don't have the choices. And they need to. I know one family that had the same type of brain cancer that had ATRT, and this family actually was cancer-free. No evidence of disease with that stem cell. However, the different breathing treatments that the mother had adverse reactions to, as soon as she left, they talked to the father and said, we want breathing treatments. The mother said no. They went behind her back and the baby was dead before she left the parking lot. That is not okay. Children are dying because they are not listening to parents' concerns. Cancer is the second leading cause of death among children and adults, and things need to change, please. Thank you for your time.
Questions, members? Thank you. Kimberly Barber.
My apologies about that. I am Moyers and Barber. Just get
Uh,
confused between.
Show your name is Kimberly Barber.
Yeah.
You're representing yourself and you're
Yes,
for the bill?
absolutely, absolutely. So, in 2014, Department of Veteran Affairs and the Government Accountability Office released a report that 307,000 veterans were killed because of, they didn't get their care in time and because of choice. That was a genocide. We don't want that in the state of Texas at all. So I am for this bill. I am for medical freedom and all its virtues. So I ask that y'all please support this, and thank you for your time.
Question, members? Ready, thank you.
Right.
That's it. Is there anyone else wishing to testify on for or against House Bill 638? Chair recognizes Representative Toth to close.
Thank you, Madam Chair, members. It was stated earlier that the federal government knows best, and that's not always the case. The Henry Ford Institute did a retrospective study of 1,250 patients that used an experimental protocol and found that 50% of them responded better. So based on that, they went to the FDA and said, we would like to do a double-blind study, right? Because that's the gold standard. And even with this unbelievable result, the FDA said, no, you can't do it. And yet hundreds of doctors across the United States, including Texas's own Rob Armstrong, have said they've had unbelievable results with it. Why is it then that the FDA is blocking their ability to do a double-blind study? We simply ask that we start trusting doctors and patients again to give them the opportunity to try to save a life. Thank you, Madam Chair.
Representative Tinderholt.
Thank you, Madam Chair. So you and I think alike when it comes to liberty and freedom. And this bill kind of brings to mind to me that if we're having people sign consent to do this and it's like a last ditch effort, that they're able to do this. So I think it's more of a statement that I support that family's right to choose. I support the individual right to choose. And I think some part of this bill has to do with the liberty and freedoms that we're given here in this country. Is that a fair assessment?
You bet.
Thank you.
With that, I close.
If there's no objection, House Bill 638 will be left pending. The chair hears no objection. House Bill 638 is left pending without objection. The chair lays out House Bill 4759 and recognizes Representative Campos to explain the bill.
My apologies. Thank you for the opportunity to lay out House Bill 4759 relating to an attack by a dangerous dog, increasing a criminal penalty and placing more responsibility on the dog owner and the local animal authority, also known as Animal Care Services. On April 24th, 81-year-old Ramon Najera was mauled to death by vicious dogs in San Antonio when he and his wife were visiting a seamstress to get his security guard uniform altered. Upon leaving the seamstress home, a neighbor's dog viciously attacked Mr. Naranjo's wife. While attempting to save her life, the vicious dogs turned on him. Mr. Naranjo was on kidney dialysis and had a shunt in his arm for treatments. The dogs grabbed onto the shunt in his arm, which caused Mr. Naranjo to bleed to death. When first responders arrived, they were also attacked by the vicious dogs. This had been the dog's third attack documented by the San Antonio Animal Care Services. Mr. Naranjo's death and the attack of 5 others who were injured brought attention to a statute restriction local animals authorities encounter. The victim of witness must file a notarized affidavit with the animal authority before it can launch an investigation. Dangerous dogs are allowed to be returned to the owners if the affidavit is not filed, which is what happened in the Najera case. HB 4759 seeks to remove the required victim's affidavit for more effective and immediate collaboration between animal authorities, local authorities, and the court system to ensure the safety and well-being of all citizens. In the same way that domestic violence cases are still investigated and pursued despite a fearful victim who is coerced or intimidated to drop the charges against the abuser, the local prosecutor can continue their case to ensure others are not victimized without an affidavit. HB 4759 amends Section 822 of the Health and Safety Code requiring animal authorities to investigate when a report on a dangerous dog is made without a sworn affidavit. Added language will lay out factors to be considered when a dog may be determined dangerous by animal authorities, and once determined dangerous, the animal authority must notify law enforcement, the local county or district attorney, and the owner of the dogs, dangerous dog owners. If an affidavit is completed, the witness information must remain anonymous. After the first dangerous dog owner's first conviction, a second indictment of the same offense will increase to a third-degree felony. This case was brought to me by the family in San Antonio, and it happens a lot. I had previously filed a bill that increased a Class C misdemeanor to a Class B because a constituent in my district got bit by a dangerous dog 2 times within 5 years because she walks to church every day. And so this is a real issue throughout Texas. I know in in Houston, there were 5 deaths that have occurred since 2022, and there were 2 in Dallas. It's a statewide issue. And so I am a dog lover. I've got 3 German Shepherds, so I know what it is to be a responsible dog owner. And this is to make sure that dog owners take responsibility and train their dogs appropriately and make sure that they are not vicious dogs terrorizing neighborhoods, which is what these dogs have been doing for a very long time. There were 112 calls made to this house. And so this needs to stop. And it's a bill that's needed. And I believe that had this bill been in place, I believe that Mr. Naranjo would still be with us today. So with that, if you have any questions, I'm here.
Questions, members? Dr. Alderson?
Thank you, Madam Chair. And Representative, thank you for filing this bill. I have 2 Rhodesian Ridgebacks at home, and although my girls are very sweet, they're also very protective. Those dogs are bred to hunt lions in Africa, and they can also make short work of baboons and other creatures that are a threat to farmers and children in particular in South Africa. And so I also know what it is to have a properly trained dog. I mean, it frustrates me that I think dogs can be a deadly weapon.
Absolutely.
And I think there are far few, not enough dog owners that recognize the fact that dogs can kill people as easily as a gun.
Right.
And if they're not properly trained and they're not properly supervised, I think then that dog owner should be guilty of assault with a deadly weapon, especially in a situation where there's a previous incident and they knew that that dog had the potential to do harm. And I want to be clear, I don't think it's the dog's fault.
Right.
This is not about punishing dogs, but this is about punishing people who can't be responsible in owning and having man's best friend turn into their neighbor's nurse, what worst nightmare. So I appreciate you bringing this bill, and I look forward to supporting you.
Thank you so much for that. And again, I am a dog lover. I mean, when I retire, I want to get a dog rescue because I love all dogs, but it's just about owners being responsible and holding our local authorities responsible so they can recognize what's going on in the neighborhoods. And if there is a dog that continuously has issues, a habitual, we need to take responsibility and make note of it. And the problem is if someone gets bit, you have to file an affidavit. Well, so many people don't want to do that because they don't want retaliation from their neighbors. So they don't file the affidavit, and then the dog can be released back to the owner, and then it happens again. And it's a vicious cycle that needs to stop. So thank you for your support. I greatly appreciate it.
Representative Jones?
Rep Campos, what happens, I see where unless the animal authorities have to report it, what happens if they don't report it? I didn't see where that was in here.
I mean, if they don't report it, the owners have the ability to, get the dog back once they pay the fees or what have you. So the authority, what they should do is keep track of these vicious dogs. And if there's an incident more than once and they need to, take it to the local authority, whether it's the prosecutor, the DA's office, and allow the individual to, press those charges.
And you're correct that they don't care what domestic violence victims, like how they feel about it. There's actually special units that jump in when the victim doesn't cooperate. But as a person who, when I was younger, was terrified of dogs, and the person who had the really mean dogs was my grandfather, and attacked my grandmother twice. And my grandfather really loved his dogs, his German Shepherds. But so I just want to thank you for filing this bill, because there are actually people who are afraid of dogs. So is this a new file?
Yes, ma'am. Yes.
Okay, all right. Thank you.
Thank
Other
you.
questions, members? Representative Johnson?
Thank you, Vice Chair Campos. I know you and I have been talking, and I appreciate continuing to talk. I've heard complaint, I've also heard habitual, and just in my legal mind, those mean very different things to me.
Okay.
Of a complaint of I'm afraid of dogs versus so-and-so was bit by a dog, or habitual doesn't mean 2 bites before. And so I just want to say that I'm going to want to continue to work on just making sure the language is clear as to
Absolutely.
when somebody can intervene, when they can't intervene, if it's just a complaint or an actual incident. And so thank you for already talking with me. I look forward to talking more.
Absolutely. Thank you so much.
Other questions, members? Representative Jones?
Yeah, with what Rep. Johnson just brought up, so are you guys discussing whether, if someone is afraid, I don't know, maybe the dog growled at him or something, or lunged at him and somebody was able to stop it, does your bill require that the dog actually attack or bite somebody
If
before?
it bites somebody, if it causes them to go to the hospital and/or death. But what I have found in San Antonio is there's a lot of complaints made about the same dogs over and over. And because that affidavit is not filed, the dogs get returned to the owners. So we want to eliminate that process and make sure that the animal authorities keep track of what's going on with these dangerous dogs and, you know, not release them and send it off to the DA's office to hopefully press charges so that these dogs don't continue to come out and bite people and or kill people.
Thank you.
You're welcome.
Other questions, members? Okay, we'll begin our public hearing and reserve your right to close. The chair calls Trevor Nahara. Up next will be Raymond Nahara. And I show that you're Trevor Nahara, is that correct?
Yes, ma'am.
And that you're representing yourself and you're for the bill.
Yes, ma'am.
Okay, please begin your testimony.
Committee, Vice, and Chairwoman, thank you for your time. I'd like to tell you about Mr. Ramon Nahara. He's my grandpa. On February 24th, he was mauled and killed by a pack of dogs, as Ms. Liz Campos had stated. I do support this bill, and effectively, I do believe that had this bill been enacted prior to this event or many other events that I've heard of over these past couple months, is that he would be alive today, or at least at the very respect that other people would not be in fear of very similar dogs that cause us to live in fear of just walking down the street. I do believe that this bill essentially gives more ability to not only the citizen, but the authorities at hand to make the decisions that they actually need to make. One thing that I wanted to make a mention on is like how they were saying about needing to go to the hospital. My thought over that was requiring medical attention, because not all the time do you need to actually go to a hospital to apply any sort of medical attention. I would like to just say, over the past couple months, I've received a number of other stories all around the city, all around Texas, effectively saying the same thing. More likely than not, it's an elderly or youth, and they are in fear of their neighbor. They're in fear of retaliation. So I'm extremely happy to hear that we can have anonymous reporting, because things like this have been reported before. 149 calls to this house, whether it's CPS, whether it's just the place around it, whether it's animals or anything that has to do with making sure the safety of the public health of that general street. I think a lot needs to be done. I think this is an amazing direction that we're heading into, to allow more ability for the citizens and the authority to make their approaches known and affected. But I also believe, and I really hope my city is listening and really listening to what I'm saying here, because things were said. You know, they want to say, you know, stop and say something. You know, be a good neighbor. Tell your neighbors what's good and what not to do, right? Well, these neighbors did do that. And that's one of the issues here, is that I believe the city is also essentially, they didn't take the right steps to do what they needed to do. Police officer says, well, ACS needs to do the affidavit. ACS says, well, no, hold on. It's the police officer that needs to do the affidavit. Okay, well, they didn't know, so they didn't even put in an affidavit. Now that person's lawyer drops because they don't see a reason why they need to pursue it, because there's no pursuant on the actual infraction. So for me, I do believe this is a great direction, but I also do believe that there's more to be done. I do support this bill, and I really hope every single one of you will join us in support. Thank you.
Questions, members?
I just want to say thank you for being here. I'm sorry, I interrupted. I'm sorry about that.
Representative Albertson.
Thank you, Madam Chair. Mr. Nahara, I'm really sorry about the loss of your grandfather. In your experience, I guess, and in your Stu, you said there were others that had reached out to you.
Yes, sir. Many others.
Are these dogs that people in the neighborhood know about? I mean, in other words, are these sort of, oh man, that's the first time that ever happened. I don't know whatever got into my dog that day. You mentioned that it was a group of dogs that attacked your grandfather. Were these were neighborhood dogs?
I don't know if I would call them neighborhood dogs, as in my term of that would probably be nicer dogs or friendly dogs. But these were dogs that were told to be kept within their confines.
And they
that
weren't?
They effectively were not.
So-
They jumped over the fence, I believe, and attacked unprovoked.
So were they known to be aggressive?
Yes, they were.
So there had been previous complaints about them or previous
Yes,
incidents?
sir. There had been two dog bites prior to that with the same dogs.
Two dog bites
Yes,
by
sir.
the same dogs prior to what happened?
Yes, sir. Yes,
And nothing was done?
Yes, sir. And that's why, I really genuinely believe that this bill is impeccably a great direction to be going into. But like I'm saying, and I hope my city is hearing me, is that I believe steps weren't taken to essentially rectify that. Because this bill is helpful, but, I mean, they said something about it. This is in record, and nothing was done for it. And from what ACS is telling us is that they either don't have the funds, they don't have the personnel, or they're scared to go down that street. They're scared to go walk down the street to do the things for us. That's why they want us to have more capability.
Well, we're going to make sure that they hear you. And again, I'm sorry for your grandfather, and I'm sorry that you had to experience that loss, but we're going to make sure it doesn't happen to anybody else.
And I really hope if this pushes through, that this will lessen the encounters and or the ability for citizens just to simply walk freely. Because right now, people are scared to walk their own streets, and for me, that's a civil infraction of their rights.
I don't know what a neighbor's supposed to do. I mean, are you supposed to walk the streets with a gun and shoot at somebody's dog as soon as it tries to attack you?
Exactly.
I mean, that's the society we're living in right now, is what it sounds like.
And it shouldn't be.
I agree. Well, we're going to help you out.
I appreciate you. Thank you.
Other questions, members? Thank you.
Thank you.
Chair calls Raymond Naharo. And up next will be Jared Mears. I show your name is Raymond Naharo,
Raymond Nahara, yes.
and you're representing yourself and you're for the bill, is that correct?
Yes,
All
Chairman
right,
Click.
please begin.
Chairman Click and committee, yes, thank you for allowing me to speak today. My name is Raymond Nahara. I'm the son of Ramon Nahara, the eldest son. Like we said, my son was saying before, on February 24th, my father was viciously attacked, mauled, and killed. Yet, while he's saving his wife from being attacked, the dogs, went to him. And unfortunately, the dogs attacked his left arm, which had a shunt. And with that shunt, it just opened up and he bled out very quickly. He didn't have any he went unconscious and he just didn't have the strength. He went down. So dogs continued to maul on him after he was down and unconscious. And my stepmother, Janie, she witnessed all this. And she stayed still, watching the dogs terrorizing to my dad. This tragedy was a landmine set up due to statutory restrictions. The dog owners were cited two prior attacks before this. By law, the ACS quarantined the dogs, the owners paid their fees, and the dogs were returned just right before my dad and my stepmom were attacked. So there was something previously done, but the affidavits weren't submitted. So that was the key. That's the gap that we have in our current law right now. No affidavits were submitted by the victims, so there's no other investigations. It doesn't go forth. There's no follow-ups. There's a few, regulations to the dog owners, but those regulations weren't adhered, and that's why they got out. They were supposed to be tethered. They were supposed to be behind a tall fence and muzzled if they were out. And that didn't happen. The dog owners were very, very, very irresponsible, so they need to be accountable for that. As my son was saying earlier, see something, say something. Between April 2020 to February 24th of the day of the attack, neighbors reported more than 150 complaints of these dog owners, from various complaints from, like from 911 to like all kinds of complaints. But the two that were most noted were the bites, dog bites. But so they had previous infractions against them. So what I say is now is that, what if the ACS officers or SAPD could have designated dangerous dogs after a serious bite? The penalties for careless dog owners would have been stronger, and the dogs removed from the homeowners. My dad would probably still be here today. The current law to classify a dog as dangerous requires a sworn statement, like we were talking before. This process adds unnecessary burden to the victim of a dog bite. ACS should be given full authority to launch investigations without sworn statements. The requirement to file a affidavit adds more emotional, financial, and administrative stress on the victims. The financial burden is to pay for the statement. There are language barriers to the citizens of San Antonio. There's a lot of Hispanics that don't have the English language and to fill out the documentations. The fear of retaliation from the dog owners, that's a major factor when you're talking about your neighbor with the dogs. And then there's emotional stress for when there are family ties. So what if ACS had the full authority to launch investigations with a previous dog bite without a sworn statement? My father probably would have been here with us today.
Your time has expired.
Okay, thank you. So I just want to say one more statement is that please pass this bill, 4759.
Thank you. Chair call, any questions, members?
I do.
Representative Campos?
I just wanted Mr. Nahara to finish what he was talking about. Sir, if you'd like, you could go ahead and finish your statement. I'd like to hear the rest of it.
Thank you. So my statement is about the rest of the bill. HB 4759 addresses gaps and makes our community safer for irresponsible dog owners. Making changes to the current law takes the burden off reporting of the victims of a dog bite injury, increases penalties to repeat offenses, expedites the process to related classifying dangerous dogs, and empowers animal control to deem a dog dangerous when any of these happen, which is a serious bodily injury, someone is transported to a hospital, a police report on the incident is written up, and an owner is arrested, or there's a sworn affidavit anonymously allowed. So my father and my stepmother were visited to this neighborhood, unaware of the dangers that lurked from the irresponsible dog owners, that seemingly quiet neighborhood. So no human should lose his life in this horrific, senseless manner. My father lived protecting his country, and he died protecting his loved one. We hope that his death would have more meaning to bring changes to this dangerous dog laws. So I hope that my father's death will motivate you to vote for this bill and save lives in the future. That's all I have.
Thank you.
Thank you, sir. I just want to thank you so much for being here and taking the courage. I know it's been really hard, but it means a lot, and I'm hoping we can get this passed in honor of your father. Thank you for being here.
Thank you, Representative Campos.
Chair calls Jared Mears. I showed your name registered as Jared Mears, and you're representing the city of Houston and BARC.
That's correct.
Animal Regulation and Care, and you're against the bill, is that correct?
That is correct in its current form. First, I'd like to give you my condolences. Chair Click and members of the committee, the city of Houston appreciates the opportunity to testify on HB 4759.
We believe the bill has good intentions, and we fully support strengthening the penalty for an offense under 822.044, attack by a dangerous dog, for a second conviction of that offense. However, there are multiple concerning things within the bill that would need to be addressed. HB 4759 would allow an animal control agency to determine whether a dog is dangerous by subjectively observing and documenting the aggressive behavior of the dog, or merely by examining the sworn statements of any witnesses. The legislation does not specify or require context, such as whether the dog was outside of its enclosure, which is what it's in the definition of a dangerous dog. In addition, no clear standard is articulated. For example, is an unprovoked attack required, or are multiple acts of aggression sufficient? The legislation instead lists several circumstances that would create the presumption of a dog being dangerous, such as any incident that occurs that results in serious bodily injury, transport of an individual to a hospital, filing of a police report, or the arrest of the owner. While these are helpful with the context of other criteria, with the exception of serious bodily injury, they are problematic as individual indicators that a dog is dangerous. In other words, the transport of a person, the filing of a police report, or the arrest of the owner do not in and of themselves mean that the dog's actions meet the definition of a dangerous dog. Serious bodily injury is addressed in Chapter 822, and there's a specific judicial procedure in place for such cases. The dog may be destroyed after a hearing and an order from a judge. HB 4759 is also concerning because it conflicts with the existing rights of the owner to appeal a dangerous dog designation. Under the proposed legislation, an animal control agency would be required to immediately notify law enforcement and a county district attorney if a dog is determined to be dangerous by the agency. Immediate notification negates the appeals process in Chapter 822, which allows for 15 days for an order to file an appeal before the dangerous dog determination is final. Animal enforcement agencies already can and do report incidents in which criminal activity is suspected to the appropriate agencies and are required by existing law to keep an updated registry of all dogs declared dangerous in their jurisdiction. This information is available to any prosecutor or law enforcement agency. HB 4759 would not add anything new to the information that is already available to prosecutors. It also includes a provision that would protect a witness's identity if that witness has given a sworn statement. While we applaud the intent of this provision to incentivize witnesses to come forward, we believe the provision would result in fewer prosecutions. In our experience, the witness is often providing the essential testimony in these matters, and prosecutors require that witnesses must be subject to cross-examination in any hearing, especially in an appeal by an owner. It's been our experience that it is very difficult to successfully prevail in the hearing if the primary evidence is merely an affidavit. In summary, while we believe HB 47459 is well-intentioned, we cannot support the legislation for the reasons articulated above. The proposed changes to Chapter 822 do not provide sufficiently specific criteria that would support a dangerous dog designation. Further failing to account for mitigating circumstances, HB 4759 does not change the definition of a dangerous dog in 822.041. We believe any dangerous dog declaration made under HB 4759's more subjective criteria would not survive an appeal. Animal control agencies do investigate these cases and can make appropriate designations without this legislation. Houston appreciates the hard work of Representative Campos has put into this bill and her advocacy on behalf of those who have been injured by dangerous dogs in this state. We also appreciate the efforts of this committee toward public health matters. We respectfully request that this bill not move forward, and we look forward to continuing to work with you throughout this legislative session.
Questions, members? Representative Johnson?
Thank you for coming to testify. I've always heard your dog can have one bite. If it bites somebody once, it bites somebody the second time, that's it. Is that a local city of Houston ordinance, or where am I getting that from?
No, ma'am, it's just a misconception.
That's a misconception, so that's not a law anywhere?
It is.
Is it what people who are good pet owners kind of,
A lot of people assume that, yes.
but that's not a law?
No, ma'am.
Thank you.
Other questions, members? Thank you.
May I say one thing? I want everybody to understand, and I don't know how other cities in the state do this, but Houston, we actually do enact dangerous dog investigations without a witness testimony. We would use the officer's testimony, which it sounds like there was an argument in San Antonio about who was supposed to do the affidavit. Is that correct?
I'm sorry, it's up to the victim to file the affidavit, and if they don't file it, the dog can be returned to the owner.
Okay. I'm just letting you all know that actually an officer can file the affidavit themselves and initiate the dangerous dog investigation. So it would be up to the agency.
I just have, I just want to ask, I know there was been 5 maulings that caused death in Houston since 2022.
Mhm.
Are you aware of those?
Well, they were actually in Harris County, not in the city limits of Houston, so I didn't investigate any of those.
So let's just say that there's a dog that's running around and doesn't really have an owner, but is in the neighborhood, and you get calls about this dog. What do you do at that point?
Well, depending on the circumstances, we answer our calls based on the severity of the situation. So if somebody calls and says, hey, this dog has me cornered up, I need assistance immediately, that would be something that we would go to. But if somebody calls and says, hey, this dog's just running around, due to funding constraints, it would be very difficult for us to get out there because there are so many calls whereby dogs are going after people.
It just seems that it happens a lot. Even dog owners, they let their dogs out. And, I know a neighbor of mine, it happened to her twice within 5 years, and she got a portion of her leg bit off. And the animal authorities had been called out. And because she didn't file that affidavit, the dog was released and, bit her a second time. So, I think it's a real issue, throughout Texas. And thank you for being here.
Thank you, ma'am.
I have a quick question.
Representative Tinderholt.
Thank you, Madam Chair. Simple question. If some of or all of your issues were addressed, is there a world where you would be for this bill and not against it?
I think there are some things that do need to be addressed.
But if those are addressed, would you be for the bill?
It's possible. It just depends on what exactly we're talking about is addressed. But I would love the opportunity to work with you. That would be great.
I'm happy to do that.
Thank you.
Thank you. Chair calls Richard Nahara. Okay, I show you registered as Richard Nahara, and you're representing yourself and you're for the bill, is that correct?
Yes.
Okay, please begin.
Okay, Madam Chair, thank you. Board members, thank you for having us here. Again, I am for the bill. My name is Richard Nahara. I live in San Antonio, where my father, Raymond Nahara, was killed February 24th by 3 violent, aggressive, vicious dogs and 2 irresponsible owners of the dogs. I support the House Bill 4759 that gives the ACS we're in San Antonio, the authority to investigate dog attacks and increase the penalty and the liability of dangerous, aggressive dog owners. Violent dog attacks are not just a problem where I live, but they're a problem all over Texas, as we discussed earlier. Some dog owners throughout Texas are weaponizing terrier breed dogs to fight, attack, kill, and destroy life. Please help make the community just a little bit safer. We need help passing this bill to put more liability on aggressive dog owners. I am for the bill.
Question, members? Ready. Thank you for being here and sharing your story. Is there anyone else wishing to testify on, for, or against House Bill 4759? The chair recognizes Representative Campos to close.
HB 4759 allows.
We are running out of time here to go to the floor here at 11.
Councilmember Kara Mendelson?
Hang on just a second.
They have 1 minute each.
Okay, you're going to have 1 minute each,
60 seconds.
because we have to go to the floor.
Thank you very much. My name's Kara Mendelson. I'm a council member for the city of Dallas, where I chair the Budget Committee. I'm the Vice Chair of Public Safety, and I'm a member of the Ad hoc Committee on Legislative Affairs.
You're against the bill, is that correct?
Testifying against, yes. I'm an animal lover and advocate. I have 2 large rescue dogs myself, and I will say, though, we have to be realistic about the need for public safety. The city of Dallas appreciates the legislature's support in wanting to address dangerous dogs in our community. However, we feel the current statute effectively addresses this process. This bill has 5 main deficiencies. First, it's denying due process. Second, it's failing to provide a reasonable and clear standard to determine if the dog is a danger. It conceals information that could taint the fairness of the sensitive process where anyone could say anything. Some of the language is vague, meaning it doesn't match the action of the evidence of a dangerous dog. For instance, when it says transport to a hospital, a person could have fainted in the Texas heat and never actually had any contact with a dog. When it talks about filing a police report, the filing doesn't prove guilt, it's an allegation.
Your time has expired, I'm sorry.
Thank you.
Wait, this one's not registered. I'm just gonna have to tell her that we'll have to be, she can put comments.
Okay. Ma'am, we're running out of time right now to go to the floor. We have to adjourn before going to the floor. I would encourage you to input your comments in the public portal. The chair recognizes Representative Campos to close.
HB 4759 allows for immediate action from the local animal authorities in order for our communities, especially low-income and densely populated, to feel safe and free to walk their neighborhoods without fear. We must strengthen the confidence in the protection of people, especially from dangerous dogs and irresponsible dog owners. I respectfully ask for your support to vote this bill out of committee in honor of the late Ramon Najera. Thank you, and I close.
If there's no objection, House Bill 4759 will be left pending. The chair hears no objection. House Bill 4759 is left pending without objection. The chair moves that the committee stand in recess until final adjournment, recess of the House, or during bill referral if permission is granted. Is there objection? Hearing none, the motion prevails. The committee stands in recess.